Alrighty. Hi, everybody. My name is Rahim Hirani. I'm an MD-PhD candidate at New York Medical College, and I will be moderating this research symposium part of HeLa Conference 2026. I would like to congratulate everybody who presented today. We had outstanding submissions, and it was a difficult decision to select. We wanted to select everybody for oral presentations, but we couldn't with the time constraints we had. But there were three presentations that stood out, and we have selected them for oral presentations. First of all, let's give a round of applause to everybody who presented today, all the abstracts that were submitted. We are going to start with our first presentation. Kyla Holbrook will be presenting her project, Street Medicine Strategies for Substance Use, Effective Interventions for the Homeless Population.
Hi, everyone. My name is Kyla Holbrook, and I'm a third-year medical student who's worked with Dr. Etienne and Rahim. Good afternoon, everyone. As I said, my name is Kyla. I'm a third year, and I'll be presenting our systematic review titled Street Medicine Strategies for Substance Use, Effective Interventions for the Homeless Population. And so this will be evaluating the evidence behind street-based interventions for individuals experiencing homelessness and the characteristics that are associated with the most improved outcomes related to substance use. So here's a brief agenda. So to give a little bit of background, substance use disorders are proven to disproportionately affect individuals who are unhoused. With a study by the Substance Abuse and Mental Health Services Administration, SAMHSA, estimating that about 30 to 50% of people who are experiencing homelessness meeting the requirements for a substance use disorder. And this is significantly higher than the general population. Additionally, overdose mortality rates are tenfold higher than, or severalfold higher than in the general population of housed individuals. And this relationship is bidirectional, with substance use contributing to housing instability and homelessness putting individuals at a greater risk of factors that can contribute to substance use. And so traditional healthcare systems kind of fail to meet this population and to reach them where they are due to both structural and logistical barriers. So most healthcare, when you think of it, is appointment-based and clinic-centered, assuming that patients are able to get there easily, assuming that patients are insured. And so this creates barriers to healthcare for individuals who may have transportation difficulties or who are uninsured. Furthermore, stigma can lead to disengagement amongst this population, whether it's perceived or experienced. Patients who feel the stigma are at a greater risk to be lost to follow-up. And so that's where street medicine comes in. Street medicine is a model that aims to address these gaps in healthcare by delivering healthcare directly to where individuals live. So this can be in street encampments, shelters, and other non-traditional settings. This can be used alongside mobile healthcare clinics, but what differentiates street medicine is that it specifically targets individuals who are living on the street or who are unhoused. And these programs tend to rely on multidisciplinary teams with physicians, nurses, and social workers all working together to address the individual's health needs and social needs. And in order for street medicine to be used effectively, it oftentimes needs to be low barrier and patient-centered to the risk that patients are experiencing. And so the purpose of our review was to evaluate the evidence behind these street medicine programs, targeting substance use amongst individuals who are unhoused, and trying to identify the most effective strategies for these programs in order to enhance future street medicine programs and implementation. We hypothesized that programs that used low barrier integrated care models with the use of a medical team and social worker team and social support would be most effective and demonstrate better outcomes as opposed to more siloed approaches. And so to go a little bit into our methods, we conducted a systematic review, as I said. We utilized three main databases, PubMed, Embase, and Web of Science. And with our initial search using key terms, we found about 254 articles. And then we went through them and excluded articles that did not meet our criteria. So articles that weren't in English, articles that only included abstracts or articles that were not relevant to the subject matter. And the main outcomes that we were looking at to monitor effectiveness of these programs was retention and care, treatment initiation rates, naloxone distribution, and linkage to primary care and follow-up. And this is just a little bit of background on how we chose our articles, as I was saying, so you can see some of the search terms that we used over there. So from our 37 articles that we reviewed, we found 5 main themes: integrated care, harm reduction, non-stigmatizing care, cultural humility, and environmental structural interventions. And then there were 5 articles who didn't fit any of these themes clearly. And so this just goes to show a little bit more on our results and how the most effective programs tend to be multidisciplinary and utilize some combination of all of these strategies. So to go a little bit more into depth on the different strategies, we had integrated care. So this involves targeting and treating disorders and conditions that individuals experiencing homelessness are more likely to have, and individuals who use substances are more likely to experience. And so one study showed that even though the hepatitis C virus burden is about 65%, or estimated to be around that amount in individuals who are experiencing homelessness, they are frequently lost to follow-up and to traditional clinic-based care. And so they found that by bringing care for hepatitis C directly to these patients, they were actually able to implement follow-up treatment. Harm reduction was another major strategy used, and one program showed that a buprenorphine program was able to report about a 60% retention after 3 months. Then non-stigmatizing care is very important. As we mentioned, that's a huge barrier to healthcare for these patients. And this goes hand in hand with cultural humility. And finally, just addressing environmental factors directly through mobile services. So what we found was that no single intervention works alone. The most effective programs utilize some combination of these different strategies and used a multidisciplinary team. Underscoring all of this and all of these approaches were an empathetic and understanding, humble approach. There were several limitations to our research, and future research should look more at long-term outcomes. And so to conclude, this is a new upcoming way for implementing healthcare that individuals can use and healthcare providers can use to meet populations who are most at risk. And us as New York Medical College students are uniquely positioned to help individuals who may benefit from these programs, since we work with many safety net hospitals such as Metropolitan, Lincoln, and so it's important to keep these programs in mind. And this is resources that you can look at later at your convenience. Thank you.
Thank you so much, Kyla. We have time for maybe one question. If anybody from the audience has any question, they can reach to the mic and ask the question. If there is none, I have a question for you, Kyla. If you want to answer, you mentioned that, as med students, we can, have a role in this. How would you go about informing these results towards policy reform?
So I think that's a really good question on how this would apply to policy reform. And we're already seeing some improvements. So when these programs first came about, it was very hard to get funding or for individuals to be covered under insurance. But now there are a lot of programs that are able to cover people using Medicaid or even Medicare. And so I think that with continued awareness and implementation of these programs, hopefully we're able to inform policy in the future. And what that would exactly look like, I'm not exactly sure, but I think research like this kind of helps us to understand what policies are needed to best implement these programs.
Thank you so much for the great presentation, Kala. Moving on towards our second presenter, Aarti Jain. The topic is Trends and Disparities in Utilization of MMA Embolization for Chronic Subdural Hematoma from 2015 to 22, a cross-sectional study of 29,290 hospitalizations.
Hi, everyone. My name is Aarti Jain, and I'm a current research fellow working with the Departments of Neurosurgery and Neurology, and I'll be presenting today on the trends and disparities in utilization of MMA embolization for chronic subdural hematoma from 2015 to 2022. And I just wanted to thank the HeLa conference for having me today. All right, so chronic subdural is an intracranial pathology that typically affects the elderly, and with the increase in aging population, we're also starting to see an increase in the incidence of this pathology as well. And it typically presents with a wide variety of symptoms, ranging from either no symptoms to headaches, gait instability, aphasia, and weakness. And it's typically caused by continuous leakage of ruptured bridging veins in the space between the dura and arachnoid mater, as you can see here. And in the elderly population especially, these veins are pretty much more fragile and more likely to rupture. And the two main treatment options that we've been seeing is historically surgery, which requires a burr hole or craniotomy in which a patient's skull is drilled into, and then the blood is drained surgically. And then there's now a newer, minimally invasive MMA embolization technique, which requires the use of a catheter that goes up to the brain and basically closes off the MMA middle meningeal artery that goes up to the brain and causes this bleed. And so by basically cutting off the supply of blood, we stop the rebleeding and then also let the blood basically redrain into the brain. And since the MMA embolization is a newer technique, we wanted to just identify how this has affected treatment for patients with chronic subdural hematoma from 2015 to 2022. So we use the National Inpatient Sample Database in order to query for patients with chronic subdural hematoma. And we group them by their treatment groups into either surgery, MMA embolization, both types of treatment, or none. And the primary outcomes that we looked at were in-hospital mortality, discharge disposition, and then also MMA embolizations per year. We also looked at the comorbidities of these patients, in-hospital complications, and length of stay, as well as patient demographics and hospital characterizations. For statistical analyses, we used the propensity score-based inverse probability of treatment weighting and the weighted multivariable regression models in order to compare the different treatment groups together in order to see the impact on outcomes and also the factors that may influence why patients go for MMA embolization over surgery. So we basically saw what we expected to see, which is that the majority of patients that did get a treatment got surgical evacuation, but a good 34% also received no treatment, which is, again, dependent on the presentation of symptoms. We also saw that the surgical trends were similar, but we did see an increase in the use of MMA embolization, which does concur with publications that were released at the time of 2017 to 2018, which did prove that MMA embolization was both safe and feasible for this patient population. We saw also that we looked at basically factors that affected whether or not patients would get MMA embolization in order to see if there were anything that we could address as a system. And we saw that patients who were female were less likely to get MMA embolization, interestingly enough, and patients that had more income, so in the Q3 or Q4 quartile of income, were more likely to receive MMA embolization. We also saw that patients in metro areas were less likely to get MMA embolization in smaller metro areas, but patients that did receive it were less likely to experience hemiplegia or coma, which are pretty severe complications after chronic subdural hematoma. We also saw that patients that did get MMA-EMBO were more likely to go home, so routine discharge without additional care. And there was no difference in inpatient death between the treatment groups. So ultimately, this basically kind of tells us how MMA embolization has been affecting the chronic subdural hematoma population. Firstly, it has gone up the rates as a result of positive publications on the treatment. And we've gone from near 0 in 2015 to over 15%, with increases that we expect to see after the results of recent clinical trials, including Embolize, STEM, and MAGIC-MT, which all showed positive results on the use of MMA embolization. So we do expect these numbers to go up. And then also, MMA embolization was associated with better outcomes. This may be affected by a number of factors. Patients that do get MMA embolization are typically presenting with less severe complications at the start, but we also did see that accordingly, they did have less likelihood of severe complications of hemiplegia and coma. And then we're also less likely to be transferred to other healthcare facilities and we're more likely to go home. And then also we found that, like I said earlier, patients that were male, higher incomes, or those seen at larger hospitals were more likely to receive MMA embolization. This could be the result of the fact that it is a newer treatment and does require an endovascular angio suite, and it does require specialized neurosurgeons who are able to basically provide this for the patient population. And so we don't see these personnel at smaller rural community hospitals. But it also does point to the fact that it is important that we do start to build community hospitals with these new infrastructure in order to provide this treatment to a larger population. Major limitations that I just wanted to point out were that we did use a database study that relied mainly on ICD-10 codes, which are billing codes that basically allow us to track what diagnoses people come for and what procedures people come in with. However, this does limit our ability to identify the need for rescue surgery, as patients may rebleed and require an additional surgery. So we cannot identify which patients had more than two surgeries. And then lastly, as it did stop at 2022, we're not able to include the effect of the landmark clinical trials. And so as a result, we're not able to see if potentially the positive results of these clinical trials have led to increased use of MMA embolization throughout the country and have maybe potentially mitigated some of these factors that we're seeing. So in conclusion, the goal of this paper is really just to kind of set a foundation for the understanding of MMA embolization in the setting of chronic subdural hematoma treatment. Though we did see that a certain group of patients aren't necessarily getting these at a higher rate, it is important to note that it is that we're at a point in time that MMA embolization has been proven as very safe and very efficacious. And so it is very important to promote broader understanding of this procedure to primary care providers, as well as patients in these rural areas to better provide care for this population. So that concludes my presentation. Thanks, everyone.
Thank you so much, Aarti. Are there any questions for Aarti's presentation? Okay, I have one. So you did mention that, MM embolization rates are lower, but they are increasing. There was like 3% just MM embolization, and then with evacuation, it was 15%. Did you see, or was there any opportunity to see the differences between outcomes between just embolization and with evacuation? And is there any disparity between that?
So we're still working on the study. So we're still trying to compare the groups, but we mainly just compared MMA-EMBO to surgery in the table that I showed. But we are continuing to work on comparing them to the combined group as well.
Great. Thank you so much for the great presentation. Let's move towards the last presenter, but not the least. We have Amber Zhao. The topic is the old wound and the absolute terror, attitudes of trans and gender diverse individuals towards pregnancy. Amber Zhao.
Hi, everyone. Thank you so much for being here this afternoon. Trans and gender diverse individuals are a medically complex group of patients that have been traditionally underrepresented and in medicine. So I appreciate you all being here today. My name is Amber. I'm a third-year medical student here. I worked on this project with my friend and classmate, Atara, who unfortunately could not be here today. And this was done under the direction of Dr. Bianca Stiffany in the OBGYN department. So Just a little terminology. Trans and gender diverse is anybody who doesn't assign as cisgender or the gender that aligns with their sex assigned at birth. The gap that we noticed is that there's little is known about the trans and gender diverse community's unique values and barriers towards obtaining family planning and reproductive care. And we decided to use Reddit to better assess this group's perspectives. Depending on who you ask, Reddit is either the best place or the worst place on the internet. For us, Reddit was chosen because of its unique anonymity, which you don't really get on other social media platforms. And for this particular population that we're studying, anonymity can be a source of protection because this is a very personal identity. Depending on where you live, who your friends are, it could be dangerous or illegal to discuss these things. So for us, Reddit was a plus. So we used Apify, which has a Reddit scraper tool, and we entered these keywords and phrases of trans and pregnant, or trans and family planning, non-binary and pregnant, non-binary family planning, etc. And so this tool scraped all of Reddit and spit out a giant spreadsheet for us with all posts and comments that had this combination of words. And our inclusion criteria was that the post needed to be primarily about a transgender individual and their relationship with pregnancy and or reproductive care. The poster needed to self-identify as a TGG individual, or they needed to be posting on behalf of a TGD individual. And then comments that were included needed to be relevant to the post. Anything that was generated by a bot, any links or images with no further context, or any responses that didn't add to the discussion, such as like, thanks, or like, I'll look into that. Comments like that were excluded. So we did our quantitative analysis, stratifying. Again, these are all posts from individuals in the TGD community. So we stratified by assigned male at birth and assigned female at birth individuals. And we found on a chi-score analysis with a p-value of less than 0.001 that folks who are assigned male at birth generally have a positive view of pregnancy, while folks who are assigned female at birth had a negative view of pregnancy. And we found that just over half of our comments were neutral and sharing information, basically. So sharing their information, their experiences, sharing scientific research information, or just asking questions and seeking out more info about pregnancy. For our qualitative results, so we use this with Atlas TI, and we went through our comments individually, and we coded them into different categories, and we found three main themes. The first theme that arose is identity-specific dichotomies, and so we found that folks who are assigned male at birth often express what they call biological grief over the inability to carry a pregnancy due to the lack of reproductive organs. And we found that folks who are assigned female at birth, they either express complete aversion to pregnancy, or they went through what we termed functional dysphoria, where these folks went through a very dysphoric process of pregnancy in order to have a biological child. The next theme that came about was the hormonal gamble. So this is, we termed it the hormonal gamble because when trans and gender diverse folks are trying to go through pregnancy or have a biological child, one of the main things that they need to contend with is whether or not they need to pause or discontinue their gender affirming care in order to go through with the pregnancy. So for example, one thing that came across a lot was this discussion of when to get breast reduction surgery and balancing their feelings of dysphoria, possible feelings of dysphoria through pregnancy versus the desire to chest or breastfeed their child. And the last theme that we found was there's a lot of clinical labor and alienation, especially in a delivery room setting, where a lot of folks were feeling that they had to bear the burden of educating their clinicians and providers on terminology or ways to be spoken to in such a vulnerable moment, and having to educate their providers on their identity and their healthcare, which generally is not the opposite of what most folks experience. And we also noticed that for trans men who are pregnant, that pregnancy could be a form of social outing, especially if somebody has consistently passed, but is now experiencing an increase in their dysphoric traits. So the biggest key takeaways from this study is that pregnancy exists at a complex intersection of reproductive desire, gender identity, and other socioeconomic factors. This is something that we know to be true, but even more so for TGD folks. And as a call to action for clinicians, we encourage clinicians to move beyond gender binary terminology and anatomical reductionism in all healthcare settings, but especially so in OBGYN. We encourage clinicians to implement a shared decision-making model to provide targeted psychosocial support for patients when it comes to balancing reproductive care and gender identity. We want to note that reproductive desire and gender identity can contradict each other. So having these conversations about what is best for someone in terms of managing their dysphoric traits and their goals of care for their pregnancy and newborn health is very personal and definitely requires a one-on-one extended discussion. And to have that discussion, we need to implement trauma-informed protocols to minimize physical and social dysphoria. And the goal of all of this is to reduce the healthcare avoidance and improve outcomes by addressing the specific fears of the TGD community. That's all. Thanks.
Thank you so much, Amber. We can take one question if anybody has any burning question regarding this presentation. All right, in that case, I'll ask the question. So you mentioned your study and the themes came up in the Reddit. Did you get a chance to look at other platforms and compare and contrast sort of what's happening in the other platforms? Because I guess not everybody uses Reddit that, especially now.
Yeah, that's a great question. So we did not look at other platforms besides Reddit for this study, largely because the amount of information that we did get from Reddit was very overwhelming, actually. And we felt that the anonymous nature of Reddit is what led to the more candid and genuine discussions. I think it's really important to note, though, that the conclusions of this study are drawn from only folks who are talking about pregnancy online. I think, the most vocal voices are the ones that we hear, and those are the ones that we are analyzing now. So as somebody who is not part of this TGD community, I just wanted to note that these are observations and not an end-all be-all for this community.
Thank you so much, Amber. Well, let's have a round of applause for all the presenters from today's session. I think once again, I would like to iterate that, all the submissions that we received were outstanding. They really did the justice to the theme of HeLa conference and the research symposium for this year. We had submissions from high school students, pre-med students, medical students, and beyond. So I think that really shows, the impact that these people are making in this arena. Thank you so much for attending the research symposium. I would like to invite Dr. Etienne to move forward with the conference. Thank you for listening for the oral presentations, and we'll see you next year. Thank you so much.
So I am Dr. Etienne. I'm Vice Chancellor and Associate Dean of Student Affairs here at New York Medical College. And
I'm Matilde Roman. I'm the Chief Inclusion and Impact Officer for WMC Health. Welcome.
Yes, welcome. This is our annual HeLa conference. We've been doing this for really, I think, over 10 years now. And really, we like to kind of keep up to date with what's happening in the times, what's happening in the world. And those are the types of presentations we will typically have at our conference. The picture you see there is Henrietta Lacks, which is this conference is named in honor of her. Welcome to NYMC. We have a few groups visiting us today, not just our NYMC community, but we have Macaulay Honors College. We have the New Visions program from Rockland County. Macaulay, you want to make a sound? And then New York Medical College, the New Visions program, folks. And the Horace Greeley High School, are they still here? They might have stepped out. They might have left already. They did their poster presentations. They probably have to get back to class, so they left. But we always, like I said, we always stress the importance of belonging here at NYMC. And in preparing for today, I have no artistic abilities at all, but I wanted to create an image that I felt kind of represents, to some degree, this conference. And one of the things that we stress a lot, you all hear about. You've heard people say, "Oh, your zip code has more impact on your health outcomes than your zip code, than your whatever." No, your zip code more than your genetic code, which I'm sure it's a mix of both of those things. So I had ChatGPT create a chromosome, and surrounding it is what some people now call the expososome. These are the various things that you're exposed to throughout your lifetime, and you can see that there's a lot of factors that go into your health. And you're going to hear about a lot of those factors today. And given that we also have a big focus on AI, I asked ChatGPT to add in the AI. And this is what it came up with. So really it's your chromosome, your expososome, and now there's the AI component that's having a huge impact on what we do. And this is why the theme for this year's conference is the new rules of engagement. That the times are changing. We see lots of different laws. We see lots of different technology coming out. And because of that, we have to really modify the way we think, the way we approach problems, the way we approach our learners, and the way we approach our patients.
Yeah. So good afternoon, everyone. Can we hear a good afternoon? Thank you. And welcome. And thank you all for being here today and for gathering community around a story and a legacy that continues to shape medicine, ethics, and our understanding of responsibility in healthcare. I want to begin by expressing my sincere gratitude to New York Medical College and their leadership for their support of this conference and the continued commitment to ethical inquiry, inclusive education, and thoughtful engagement with the complex questions that shape healthcare and research. Creating space for this kind of dialogue matters now more than ever, and it reflects leadership that understands both our history and our responsibility moving forward. The HeLa story begins with Henrietta Lacks, a woman whose cells were taken without her knowledge and went on to transform modern science. Those cells made possible breakthroughs in cancer treatment, vaccines, and countless medical advancements that have saved millions of lives. And yet for decades, the woman behind the science and her family were excluded from recognition, consent, and benefit. This conference exists because the HeLa story is not just history. It's a mirror. It asks us to reflect on who benefits from medical progress, who bears its burdens, and whose voices are centered or overlooked along the way. It challenges us to examine how power, race, access, and trust intersect in healthcare, research, and education. This year, we are grounding our time together in a set of new rules of engagement. The new rules of engagement ask each of us to move beyond observation into responsibility. How we listen, how we question, and how we show up when equity and ethics are at stake. An opportunity to establish shared commitments to lead with dignity and respect, to assume good intent while remaining accountable for impact, to challenge ideas and not people, and to create space for honest, sometimes uncomfortable dialogue in service of learning and growth. Today is not only about honoring Henrietta Lacks. It's about learning from her legacy in ways that reshape how we engage with our patients, our communities, our colleagues, and one another. It's about recommitting ourselves to ethical care, informed consent, transparency, and respect for human dignity, not just in principle, but in practice. And as we move through today's conversations, I invite you to engage with curiosity, humility, and courage. While some conversations may challenge us, when approached with care, can deepen understanding. And so the space exists to support thoughtful exchange, shared responsibility, and meaningful learning beyond today. Thank you for the speakers, the organizers, and partners who made this gathering possible, and to each of you for showing up with openness and with intention. Thank you.
Great. And also thanks to our awesome, amazing AV crew who are just an amazing job all the time, making sure that everything is operational and works well for us. So we're going to start by having our Dean of the School of Medicine, Dr. Schluger, come up to give some opening remarks.
Thank you very much. Well, good afternoon, everybody. I'll be brief because I know we're running a little bit behind. I just want to first extend my gratitude to Dr. Etienne and Mathilde Roman for being the co-chairs of this conference, also for Dr. Etienne, really for starting this conference so many years ago. For me, the HeLa annual HeLa conference is really one of the highlights of the academic year. It's something I look forward to every year. And I think this year's conference looks like it will live up to my expectations, and I'm sure all of yours as well. I want to also give a special welcome again to the students from the Macaulay Honors College of City University of New York, to the students from New Visions, from Horace Greeley High School, and of course, our students and faculty from New York Medical College. As Dr. Etienne said, we are really living in a new world, and we do need to understand what the rules of engagement for this new world are going to be. We have tools at our disposal that I think were unimaginable for most of us even a year ago. I can just say anecdotally, when you play around with some of the artificial intelligence tools that are publicly available, what you can do now seems infinitely more powerful or more impressive or frankly scarier than what you could do even 6 months ago. And I think all of us are in some ways excited by that, but also intimidated in a way. So I'll be interested to hear what the speakers have to say about it. On the other hand, for those of us in medicine, I still always think the heart and soul of medicine is a physician sitting at a patient's bedside, trying to help that person in the best way that he or she can do that. And nothing will really ever change that. These things that we have, like artificial intelligence, are tools. They're not human beings. They're just tools that we can use to help us do our jobs better. And I think that's how I think about these sorts of things. What do we do in medicine that we think we do well? What do we do in medicine that we think we don't do well? And what could we do better? And how can we use these tools to help us do our jobs better? So I'll look forward to the remarks from the speakers this afternoon. And again, I just want to extend my gratitude to Mil Etienne, Mathilde Roman for their leadership of this conference. And I hope everyone has an enjoyable afternoon. Thanks very much.
Right. And I did want to also recognize the folks out in the Zoom world. We do see you. Well, we don't see you, but I see you. And I am going to be looking out for your questions when we get to the Q&A of these presentations. I think we're going to be ready for the first speaker. We're gonna move to our first speaker. I'll be introducing Dr. Joshua Budhu. Dr. Budhu is a neuro-oncologist and physician scientist at Memorial Sloan Kettering Cancer Center and Weill Cornell Medicine. His work focuses on improving access, affordability, and equity in neuro-oncologic care through health services research, clinical trials, and patient navigation interventions. He holds national leadership roles in neurology, neuro-oncology, and health equity, and is committed to translating research into policy and practice that improves outcomes to underserved populations. And I'm also proud to say that we serve on the board of the New York State Neurological Society together.
Great. Thank you so much for that introduction, Dr. Etienne. And yeah, just very happy to be here to talk about some of the work that I do. So for this talk, the title is When Coverage Changes, Outcomes Change Access and Financial Toxicity at the Bedside. And I'm going to talk a little bit about some of the work that I do, particularly in financial toxicity. And I'm just going to, these are just some of my disclosures. They're all related to health equity research. So the agenda for today, we'll talk about some kind of general healthcare spending in the United States, how healthcare is financed. Then we'll talk about how that cost really is passed down to our patients. And then I'll bring up the subject and topic of financial toxicity, which is something that's a little bit new, but it has a profound effect on our patients. And we'll kind of end with the theme of the day. We're talking about some of the latest coverage changes over the past year and how that also affects some of our other patients. So this is just a graph looking at the healthcare spending of OECD countries. And you could see, let's see if I can get this. All right, maybe not. But this is I'll probably avoid that. But this is the orange kind of bar is the line for the United States. And this is a percentage of healthcare spending as GDP. And you can see that in 1980, these are our comparator countries. So we're compared to France, Germany, Switzerland, New Zealand, Canada, Sweden, UK, Netherlands, and Australia. And at 1980, even though we were at the top of the leader in terms of our healthcare spending as a percentage of GDP, we were still within the trend. But you can see that within the past 45 years, we have really exponentially increased our healthcare spending. So we spend about 18% of our gross domestic product on healthcare. And for a true value or true dollar amount, that's about $5 trillion. So to put that into perspective, Germany, which is the third largest economy in the world, their gross domestic product is about $5 trillion. So we spend more money in healthcare than the entire economy of Germany and every single other country except for China. And with that healthcare spending, do we actually have better outcomes? And the answer, unfortunately, is no. You could kind of see here where on this graph, there's a healthcare spending is on the x-axis and health system performance is on the y-axis. And you can see that the US, we spend the most amount of money, but we have some of the worst outcomes. And unfortunately, when we look at some of the other comparator countries, they're all really here in the middle. And higher health system performance refers to life expectancy, refers to morbidity, refers to a lot of very metric and guideline concordant care. So basically just following different guidelines as well. And one kind of takeaway from here is also to realize that the US is not a monolith. So we are bigger than all of these countries. And some states, so for example, if you take away Massachusetts or Colorado, they actually place around here. So their health system performance is actually quite high, but their costs are high as well. But when you combine the entire United States with some states such as Mississippi or Alabama, in which unfortunately their health system performance is quite low, we end up here in the US. And with that amount of money, where does that actually go? So that $5 trillion, about 31% of it, or 1.5 trillion, goes to hospitals. So that's, the hospital I work at, Westchester Medical Center here. This also includes, cancer centers, children's hospitals, long-term acute centers. And, when we talk about some of the other costs, you can see that physicians and clinics, so this is kind of going for outpatient or ambulatory care, that's 20%. But one kind of thing that's often surprising is that prescription drugs only account for about 9%. And that's something that's probably outsized that we hear about healthcare spending, about we need to reduce prescription drug cost, which that definitely is true. But in terms, it's less than 10% of total healthcare spending. It's still a lot, so that's a little bit less than $500 billion. But if we decrease health spending on prescription drugs by 20 or 30%, we're only going to be decreasing overall healthcare spending by a couple percentage points. The other thing that's kind of a little bit unfortunate or shocking about the US is this other health kind of bucket, which is over $1 trillion, and that includes administration. So this is basically money that's not spent on direct healthcare, but is really spent on supporting the system. And a lot of this, unfortunately, likely is there's a good proponent of waste. So how is that healthcare really, who actually pays for that? And this is a chart from from CMS that looks at, what is it private? Is it Medicare? Is it Medicaid? Who pays for healthcare? And kind of the big takeaway from here is that private health insurance pays for about a third of healthcare in the US. The government actually pays for 50%. So if you can see, Medicare is about 23%, Medicaid 17%, and then this all other includes TRICARE, includes the VA system. And the government actually pays already for 50% of all healthcare in the US. Out-of-pocket costs are about 12.7%. Sometimes it's a little bit, that's likely going to be a little bit higher in the future given recent changes. But another kind of takeaway is that, we always talk about universal healthcare and, what's that going to do to the private health insurance market? But we are already a half, government supported and sponsored healthcare system. And that cost, all that money and all the, we saw the out-of-pocket cost, all of this eventually trickles down to patients. And this is a survey from the Kaiser Family Foundation from 2022, and they looked at adults about if they had medical debt, and 4 out of 10, so 41% of adults had some type of medical debt. And a decent proportion, 24%, said they had bills that they are unable to pay. 17% had to use, are basically debt that is in, they had to use loans to pay for. And, kind of also the other takeaway too is that, as we talk about medical debt, one of the numbers are still a little bit unclear because of how much money it is, but in total, medical debt is the #1 cause for bankruptcy in the United States. And how, with that kind of cost, like what do patients actually experience? What do they pay for? And this is from that same survey looking at, what were their bills caused from? And lab fees or diagnostic tests were the highest, followed by doctor visits. And you could see that the prescription drugs were still, kind of in concordance with the previous slides, were only about 27%. And one of the interesting things is, these tests, X-rays and MRIs, a big part of this is due to how healthcare is really paid, or healthcare pricing is not very transparent in the US. I'll kind of just shout out, does anyone know how much an MRI can cost in New York? You said 50,000? All right, that's a little bit higher, but it can range actually. If you pay out of pocket, it can cost $2,000 at some private imaging centers. Some of our large academic places will charge $12,000 to $15,000, and that's for the same exact test. And this depends on different contracts that they have with insurers. And as a patient, you end up actually, because of co-pays, because of out-of-pocket cost, a lot of that money actually comes down toward into your actual bill. And when you can kind of think about, healthcare is one of the only things in the, in our world where we don't actually have like pricing or transparency of pricing, whereas normally you can go online on Amazon or something and look at how much something costs and can compare it. One of the kind of things that we've done at our center is also look at some of the other smaller costs. This is a study that we did looking at parking costs for our hospital. And, we looked at our hospital as well as others in New York and looked at other comprehensive cancer centers. And, unsurprisingly, we found that New York has the highest parking cost. And, when we try to add it up, we kind of looked at different diseases. So I'm a neuro-oncologist. I take care of patients with brain tumors. So for glioblastoma, the standard of care is 30 fractions of radiation in the upfront setting. That means you have to come to the center 30 times. And our parking is for about 2 to 3 hours, can go up to about $30. So you can imagine that if you're coming here 30 times within the span of a couple months, times $30 plus congestion pricing, plus tolls, plus gas, all the other things that come with a car, this adds up to thousands of dollars. And then another kind of thing that people have looked at too is that some hospitals actually have very high price for their cafeteria, and actually that's one of a decent money maker. And one of the kind of things is that healthcare itself is such a huge business that all of these costs end up adding up. And with that, transportation bill being maybe a couple $1,000s, do people actually have money to pay for that? And for the majority of Americans, the answer is actually, no. Half of adults in the US would not be able to pay off immediately an unexpected $500 medical bill. And this is also from the Kaiser Family Foundation survey in 2022. Potentially, this is even higher today because of there's been a decent amount of inflation and some other kind of coverage issues that have come up. But a lot of people said they would have to put an unexpected bill on their credit card. They'd have to borrow money from like a bank, payday lender, and they would have to come up with some kind of payment plan. So people really don't really have this type of money or this type of fallback to pay for these bills. And that leads to something that's called financial toxicity. So this is a more recent kind of concept in medicine. And the toxicity really refers to, it's the same thing as a side effect toxicity from a drug. So this is the toxicity, the negative impact of healthcare costs on a patient's financial well-being and quality of life. And it encompasses the financial burden that patients, their families experience due to medical bills, lost income, and other related costs. And this is a framework that we use when we look at financial toxicity, because there's two different sides to the coin. One, there's the objective cost of how much money that you spend on healthcare. Then second, it's the psychosocial stressors that comes with worrying about bills, talking to debt collectors, and worrying about if you're going to pay for your healthcare. And that subjective part leads to anxiety, discomfort, leads to worse quality of life. And there's actually a decent amount of evidence that depending on some of these symptoms, you actually have worse outcomes. And for us, cancer specifically, the amount of depression and anxiety and other psychosocial stressors you have actually leads to worsened immune response and actually can affect some of the therapies that we give, such as immunotherapy. Yep. Ah. All right, I'll stay over here. Actually, I can't really see the screen, but so I might be looking down for a little bit. The other part is looking at the expenditure, so the direct costs. And direct costs are kind of what I mentioned about, the parking costs, the co-pays that you might have to pay for a medication or for when you go to a doctor's visit. But then there's also these indirect costs. And think about that example I gave about someone who has to come for 30 fractions of radiation. They are likely not going to be working during that time. And depending on the disease severity, they're likely going to have a caregiver bring them there. Is that caregiver able to take off work for 30 days and go back and forth and chaperone this person? And this leads to decreased income. This can lead to, especially if you don't have a job that has medical leave or paid medical leave, you just really lead to direct loss of income. And that leads to non-adherence. You don't come to your appointments because copays might be high. Leads to medication non-adherence because you are trying to not pay for an expensive medication. Probably the one in the news that most people know or hear about is the insulin rationing that happens because of how expensive insulin is. All of that leads to worse outcomes. And we found that in oncology and cancer care that at least 30% of people, it's likely even much more, 40 or 50%. Some of that variability is due to the screening tools that we use. But at least 30+% of people have experienced financial toxicity. This is a recent study that looked at cancer survivors and how much experienced financial hardship. And you could see 34.2% experienced hardship. And on the right is a graph that looks at people who have financial hardship and whether they have trouble with health-related social needs. These are things such as food insecurity. Can you buy food, or can you go to the supermarket and provide food for yourself or your family? Housing insecurity. Do you have enough money, or are you able to stay somewhere? Transportation barriers. We kind of talked a little bit about that as well, and we saw that. And if you have some type of medical financial hardship, you are over 50% of people have trouble with one of these things. I'll talk a little bit about food security a little bit later, because that is something that has become so prevalent in the US currently, and a decent amount of that is recent changes with inflation, the cost of food, and just being people able to provide food for themselves. So at MSK, I'll talk a little bit about the group that we do, that some of the work that we do, because we study this. We also created a few programs to try and address this. And I lead our affordability working group, the research side of it. But our kind of analysis of 90,000 of our patients saw that at least 25% of them face financial hardship. And we've created this group that is, there's physicians like me who do a lot of research, but there's nurses, there's our financial services team, social workers, case managers. Some of our hospital administration going up to the C-suite are also involved in this. And we combine our research with interventions and quality improvement projects. This has led to basically a universal financial toxicity screening program at our hospital, including a navigation program that we pair with different initiatives. And this is just one of our recent papers that looks at that health-related social risk. And the kind of takeaway from this is that patients who were undergoing radiation had higher food insecurity, housing insecurity, transportation insecurity, and had to borrow money. And what we're kind of seeing is that depending on the type of treatment you have, which could be, it could be inpatient, or it could be infusions, or it could be expensive targeted therapies, which can cost $200,000 to $300,000 per year out of pocket or at cost. We see that depending on your treatment, your treatment directly relates to the increased amount of financial toxicity that you can experience. This is just kind of the program that we set up. It's a little bit of a busy slide, but you can just see there's lots of steps here. And what we've done is that we've embedded financial toxicity screening within many aspects, so that if a patient, for example, doesn't get screened at the beginning, they'll eventually get screened, on the second or third visit. And we've also incorporated it so that it's patient-facing, so they can input certain information, but then also physicians, nurses, we also have that conversation along with social workers. And when we do screen someone positive, or someone screens positive for financial toxicity, we have quite a few programs that we can offer. So this is just one from the Immigrant Health and Cancer Disparity Service that it's called the Integrated Cancer Care Access Network. But we have a huge program that's sponsored by a decent amount of funding from both private and public sources. But if someone also tests positive for financial toxicity, we ask them about food insecurity, and we have a large food bank. We have help with housing and employment. We have a direct connection with New York Legal Aid Group. And we have a transportation subsidized part. Financial has been a little bit harder lately because a few years ago it was easier to get grants and direct money for people, but it's some of that money has dried up lately. And this is just our food pantry program. In terms of scope, we've given about 500,000 meals over the past 10 years. But even with screening, we still miss a lot of people. This is one of our recent analysis from last year. But out of 3,300 people who had positive screens, we actually weren't able to provide an intervention or help half of them. A decent amount of them actually just didn't want to be contacted by us. Again, I think part of that was basically fatigue from the healthcare system. They had another person who's calling them, asking them, "Oh, can you tell me about your finances? Can you tell me about XYZ?" And actually, a decent amount of people feel that it's not the healthcare system, or they don't want to divulge their finances to us. Part of that is in a well-documented phenomenon too, is that people think that we might not offer the best types of treatment if they assume, or if they think that we can't pay for it, or they can't pay for it. But this kind of work has really kind of led to us to try to really nuance this and figure out where are the gaps that we're still facing with this program. So, it's a great program. I'm happy to be part of it. We do lots of research, and we try to inform some other kind of like policy with a lowercase p. But is that really enough? And to be honest, what we're doing is almost like a Band-Aid in the system. And going back to that financial, or like the overall healthcare spending, there are so many different levels of both drivers of disparities and interventions related to financial toxicity. This is the social ecological model. It's been used for a variety of different interventions in community health. And this is one that we adapted for financial toxicity. And I mentioned about healthcare insurance and access. And we're helping people, and sometimes we give direct money to people. But we're actually kind of fixing a problem that is more upstream, in which people have out-of-pocket cost. And the kind of big takeaway, as you see here, some of these drivers, there's the insurance from the top and medical debt. And there's also these billing practices, parking, transportation I mentioned. There's geographical barriers and travel burdens as well. And when we think about interventions, besides some of the institutional stuff we think about how can we affect change at the policy level? How can we do things also interpersonally, like making sure that this is a topic that's talked about, that patients know about their resources? And one of the, I think the takeaways is that we need to really be thinking at a broader level for a lot of these interventions. And I'm going to kind of move really quickly to one of the vulnerable populations that we take care of and kind of that I do a lot of research and study with is that I work with a lot of, or with emergency Medicaid patients. So these are mainly people who have immigration, they're immigrants without authorized immigration status. And there's been a lot of recent changes to Medicaid enacted over the past year. Some of them don't come into play until later this year and next year, but there's going to be different work requirements. There's a lot of different changes with cost sharing, and this is directly going to affect New York. So the essential plan, for those of you who are not familiar, this is for people who didn't qualify for Medicaid. They have they're like 138% of the federal poverty line, but New York provided basic insurance to them as well, and it's very similar to Medicaid. So there was an expansion program up to 250% of the federal poverty level, which is not a lot of money, but that had to be taken away with the recent changes. And now actually there's with the current budget proposal for the governor's proposal is that without some additional funding, they might shut down the entire plan, which is 1.8 million people who are enrolled on this. And when we think about, the new rules of engagement and directions, this is just a graph looking at healthcare insurance and number of people who are uninsured in the United States. And it was rising until the Affordable Care Act. And for all of its pitfalls, it did stop the rise of people being uninsured and kind of stayed the same. What we're going to see is over the next few years is this is going to tick up again. And what does that kind of cause? I mentioned I take care of a lot of patients, or I kind of work with different groups, and we do work with immigrants without authorized immigration status. This is probably the most vulnerable population that we're going to see lose a lot of coverage. And part of this is also data sharing agreements. I think some people have seen, but CMS has entered an agreement with ICE to provide information about Medicaid enrollees who may have immigration status that's not authorized. And this is one of the things where we talked about public charge, we talked about other, we think about other like rights. This is the government who, we always tell our patients if healthcare is a right, but this is the government actually using that against people to find out if you're undocumented or not. This is just as I'll kind of end on a little bit of maybe this is a little bit of a tangent, but we looked at some of the Medicaid expenditures and emergency Medicaid, which I mentioned. Emergency Medicaid is really just for the use for people who are without authorized immigration status and for those who are not eligible for Medicaid because they haven't been in the country long enough. So also legal residents as well. And this covers for really emergency services. And the CMS has indicated they're trying to take this away and try to really limit it. But it's really a drop in the bucket. And it's less than 0.5% of the entire Medicaid budget. And I always like to kind of put it back, because what we've seen also too from tax revenues is that this population actually contributes about $20 billion to Medicare, about 20 million to the Medicare Trust, and about over $20 billion to Medicaid in itself. So they're paying so much more in terms of what they're actually getting back. And that's something where I think it's helpful just to put it into perspective. So kind of end with looking back at this model again, because as we think about interventions, as we think about where do we go from here, as we design things, we need to be looking at all different aspects, and we can't just be looking at an individual or what our organization can do, but how we can also affect things at the policy level or societal level. So just some takeaways: financial toxicity is a growing problem in medicine, and not just oncology. It was described first in oncology, but it's all throughout. And we need multi-level solutions. And the current policy is actually making a lot of this worse. And our most disadvantaged patients and populations are the most vulnerable. And we just really need to continue advocacy, research, implementation is driving for change. And this is my email address if anyone wants to get in contact with me. I list all these funders here because also just to show there is quite unity between both private as well as public, as trying just to help patients wherever they are. So thank you so much and happy to take any questions.
Thank you very much for that excellent and comprehensive talk. And I know Dr. Block is going to probably go into some of those Medicaid points that you were bringing up a little bit later. We have time for a few questions. Let's see here. We need a mic. Oh, Dr. Schluger has a question. Do we have a circulating mic?
Yeah, thanks very much. I thought it was a really terrific talk. You spoke mostly about costs. I wanted to ask about charges, because that's all we really know about, or most of what we know. We know the charge. We don't really know the cost. And particularly in oncology is a good example, right? Oncology drugs, many of the newer oncology drugs, the charges are based not on some expectation of a profit margin the company wants to make, but what they call value-based pricing. You know, this is worth $150,000 a year to your life to pay for that drug. So what about putting pressure on charges? And it's not just drugs, right? A colonoscopy, a screening colonoscopy at 10 different hospitals in New York, the charge there can vary by as much as 100%. So what can we do to control charges? Since, as I said, you spoke mostly about, Josh, paying higher costs, but
so they can see you.
Shouldn't there be pressure to reduce charges?
Yeah, so I think that's a really, really great point. And I think one of the ways that we can kind of look for help is what do other countries do? And a lot of other countries, they use health technology assessments to really engage, is something worth it? And as you mentioned for oncology, we have a lot of really expensive drugs, and some of these, to be honest, don't really meaningfully extend life or also meaningfully extend quality of life, but they, their charges are $300,000, $400,000 as terms to what the insurer pays. It's a little bit muddier, but I think what we kind of traditionally, we've always had the FDA look basically at safety. I think what we also need doesn't necessarily need to be a government agency, but we do need like an independent agency that really looks at, you mentioned a little bit about, basically cost effectiveness or like quality, or like dollars. Like, I think we need, in my ideal world, we'd also have an organization that helps with pricing, and helps with kind of approving medications or procedures if it hits a certain threshold for pricing. And with that, would also have regulation about how much people can mark up some of these costs. If we look back to, I guess one of the things is looking at if you're going to a private foundation or private healthcare provider, fine, they could charge whatever. But if we're talking a lot about these hospitals, which are nonprofit and also require a lot of other things or get a lot of benefits back, then they should be under regulation about some of this pricing.
Thank you. Over here.
Hi, you mentioned in your presentation how hospitals are one of the most highest institutions that get most of the money. And I was just wondering, I'm not sure if you'll be able to answer this, but if you ask for a broken down bill after a hospital stay, you could notice how one Tylenol is $100. So my question is actually very similar to Dean Schluger's. But is there a way that we could kind of are hospitals able to put a cap on stopping to raise the prices on common drugs on Tylenol or let's say a Band-Aid, stuff like that? They substantially raise the price. And I know it's a business and I just feel like healthcare, that's not the point of healthcare. So it's hard to understand why hospitals would do that. I don't know. Yeah. So
a lot of this goes to how things are priced in general. And I think one of the easiest ways to think about it is incentives. And, what incentive does a hospital system have to kind of break down a pricing or kind of either price transparency or in terms of drugs or kind of outline this. And one point I'll say is that I mentioned that's the cost for all hospitals. A decent amount of hospitals are struggling. So safety net hospitals, a lot of rural hospitals, and even though their prices, we look at it, and we think, oh, this is astronomical, they are barely making ends meet, or they are in the red. And we've seen some of the largest rural hospital closures over the past 15 years because of this. And this, I think, is just honestly it's a symptom of the system that we have, in which, what incentive does let's say a for-profit hospital or even a nonprofit hospital, what incentive do they have to lower their prices? Especially, the other kind of argument you can make is that if they lower their prices, is that actually going to affect the patient? Or is the insurer, or is it going to be some other cost that's passed down? Maybe it's to society, that in terms of overall funding or taxes, but to the individual patient, for them, their bill might not change at all, whether it's they were charged 50,000 or 100,000, or their out-of-pocket costs might not change at all, depending on their insurance. So I think a lot of this is thinking too about incentives. What incentive does someone have to change the system or so, and where do we all fit in?
Okay. One last question from Dr. John.
Hi, thank you very much for an extraordinary discussion. This is a very complicated area, and there's several areas that really bother me as I look at it and review some of the details. One is that the increase in, obviously, profitability of private insurers, particularly as they become managed Medicaid or Medicare users, watching their valuation go from hundreds of millions to the billions. Is there a way to address this? I see that Congress, to some degree, is looking at it, but do you think this is a significant thing that we need to look at, and so we can get better outcomes? Because when they manage it, which means we get less access to care, and that's what bothers me.
Yeah, and I think that's a really, really wonderful point. And I'll say that a little bit of a pessimistic view is that every change that's been made, someone figures out how to game the system to either make more money or profit for them. And that's why there's that huge bucket of, $5 trillion. And where does, administration came up for, it's probably over $1 trillion with that. So it's a little bit of so this one's harder too, especially with a lot of the managed Medicaid plans. The answer I'd have to give would probably take a lot longer than a few minutes. But I think probably the biggest thing is that as we hopefully strive for a little bit more change and for a little bit more kind of regulation, public sentiment is, as we've kind of seen from recent events, public sentiment is, very focused on affordability and very focused on cost and being conscious about cost. And I think probably the best way to go is that, regardless of what administration is on, is that this is an issue that both parties it's basically nonpartisan, or it's bipartisan, that people want to drive down cost or also drive down profits, especially at the expense of people. So I'll kind of end on that, where there is a lot of work that needs to be done. It's a little bit complicated, but I'm a little bit hopeful that, given that we have support on both sides, that we will see some changes.
Excellent. Thank you very much. A last round of applause. Yeah. Excellent work. We are going to have our county executive, Ken Jenkins, is going to come up and give brief remarks before we hear from Dr. Milligan.
We're doing this very formally this afternoon. Make sure we get all the right mics. Speaking of formally, it's a genuine pleasure to welcome back to New York Medical College our county executive, who, and this is breaking news, he was just named by City and State New York to be one of the 2026 Black Trailblazers, notable New Yorkers who are paving the way for others. The Honorable Ken Jenkins, ladies and gentlemen.
All right, so first, good afternoon, everyone. Okay, certainly it's an honor and a privilege to be here again. This is my second year in a row to do this particular ceremony, this symposium, the work that you're doing and getting yourselves set up and excited, as whether high school and some college folks and some people that just are monitoring coursework and talking about doing research, and specifically as you go involved and get involved as far as equity and making sure that there's research, that there's more targeted ethics in your research as you go along. When we have this opportunity in New York Medical College, and let's give another round of applause with Dr. Alexander and all the team that continues to pull all these things together. The work that you're doing in this symposium is setting you up for the exciting opportunities that happen in research. One of the things that we have in Westchester, we're so blessed to have some of our leaders. I'm not going to name them because I'll get myself in trouble if they're not people that are supporting the New York Medical College mission, which they all are, by the way. But your time and energy and effort is so critically important to be able to set this particular pace, to set this opportunity, to learn from each other, but more importantly, to get yourselves on that path to continue to move forward. So I want to say thank you and congratulations to all of you for participating in this very important symposium, but more importantly, understanding that you're on a path to succeed, and New York Medical College is going to be helping you get along that way. So best of luck this afternoon. I know that I'm standing between you and snacks later on, but more work that has to be done. So best of luck, everyone.
Thank you very much, County Executive. We really appreciate you taking the time out of your very busy schedule to join us. And I appreciate you highlighting our high school and college students visiting. It's a big deal that they're coming out to get these important lessons. I am really honored to introduce the next speaker. Dr. Tracey Milligan is professor and chair of neurology at New York Medical College and WMC Health, where she leads system-wide clinical, educational, and research initiatives with a strong emphasis on innovation, quality, and access. An epileptologist and nationally recognized clinician educator, her work has been honored with numerous awards for excellence in teaching, leadership, diversity, and innovation, including the Bernard Loan Award for Excellence in Teaching, the Harvard Medical School Harold Amos Award for Diversity and Inclusion, and the Barbara J. McNeil Faculty Award for Exceptional Institutional Service. She has received multiple national awards for leadership, teaching, and innovation, and is the 2026 recipient of the American Academy of Neurology A.B. Baker Lifetime Achievement Award in Neurologic Education, which she'll be getting in 2 months, right? She'll receive it in April. Awesome. So it gives me great pleasure to present Dr. Tracey Milligan. Thank you.
Thank you so much, Dr. Etienne, and so wonderful to hear from Mr. Jenkins, too. I want to thank Dr. Etienne, Mathilde, New York Medical College Dean Schluger, and the organizers of this conference for inviting me to present today. It's really an honor and such an important topic, important conference. I also want to join in welcoming the Macaulay Honors students here and the New Vision students here as well. We hope you're all going to become neurologists. Or otherwise help people in need. But you will hear the neurology theme come up in my talk because I am a neurologist. I also want to invite welcome Georgie and Karen for being here today, and all the other future neurologists who might be watching. And my talk today, what I'd like to do is actually to start with a patient story. And first, my disclosures. So you can see those here. But I'm going to start with a patient story of a patient that I saw a number of years ago with transient global amnesia. Now, transient global amnesia, for those of you who have not seen it before, is a temporary inability to form new memories. It's like the record button is broken. And so this patient had transient global amnesia. It usually only lasts a few hours up to a day. But during that time, he had no memory of anything that had happened to him in the emergency room, nor any memory of all of the tests that he had had. But when I went to go see him the next day, along with the resident who had cared for him overnight, a resident who is known for being incredibly kind and empathetic, the patient reported he saw the resident and he instantly felt safe and comforted. And so even though he didn't remember anything about their encounter, he had that safety, that warmth that came along. And so what that makes me think about is how what we're doing, it's not what we put what we record or what we put in the record, it's that human experience and how important that is. Human first. So you saw that image I showed you. My images I'm showing you were generated with AI. And so I asked AI, I said, take this image, it's not quite right. Make it clearer that the recording is broken and put a caring male physician with an empathetic demeanor in the image. This is what I got. I said, oh, well, this is what AI thinks. If you're empathetic, you're wearing a tie, you're married, looks like you're half in bed with the patient. So there's but this is what we're thinking about. How is AI making these judgments? By what we program, by what we input. Now, transient global amnesia was first described by somebody who taught me, C. Miller Fisher. And so he was one of the first neurologists to describe this transient global amnesia. I learned from C. Miller Fisher, and he did bedside, he did teaching rounds with the patient. And we would bring the patient into the library where this portrait was hanging on the wall. And Dr. Fisher would sit here in front of the portrait talking to the patient. Well, one day he was examining a patient who was confused. As part of why he was in the hospital, he had confusion. And I was in that room. I saw the patient look to Dr. Fisher, then look up, back to Dr. Fisher. I said, well, we're really causing some confusion here. But, again, it's another way to think about that real presence and the artificial, and how can that sometimes detract from the care that we want to give. So going back to what I'll be talking about today, human first, new rules of engagement in an AI-enabled world. I'd like to start with saying, AI is not a threat. AI is not evil. AI is not anything. It's not primarily a solution. It's not primarily a threat. What it is an accelerant. So with AI, we know good systems can get better. Bad incentives scale faster. Bias spreads faster. And insight can spread faster as well. Also, AI is pretty good at making graphics on PowerPoint. Thank you, Copilot. So when we think about accelerants and changes and what happens, one of the recent examples we can look at is the electronic health record. And so there was a time when physicians hand wrote notes in the chart, and computers were not involved in medical care. And so with the electronic health record, a new technology in medicine, there were a lot of changes that happened. There were a lot of changes. Suddenly people could actually read what doctors wrote. So there was safer care as part of that. There was the ability to harness more data for research with electronic health records. But there was also a barrier that was created between the doctor and the patient. And you've probably seen some of those cartoons where the doctor is just looking at the computer and not even looking at the patient. So it created an artificial barrier. It also created, rather than helping the doctors necessarily with work, it created work for us. And during this era of the EHR was when the term moral injury, as it applied to physicians working in the healthcare system, was coined. So we had gained things with technology, but we have to be focused on the cost as well. The EHR was a form of disruptive innovation. Disruptive innovation was a term that was coined by Clay Christensen, who was a professor at Harvard Business School. and was by The Economist was dubbed as the most influential management thinker of his time. He described this disruptive innovation. And so you have a very, very strong system or very, very strong company that it is continuing to get more users, more people involved, and then something brand new comes on. And it is so easy to use. It works so well that it quickly overtakes the traditional technology or the traditional business, and sometimes they go out of business. So one of those examples is maps and atlases. And now we have our navigator on our phones, right? We don't need it anymore. So at one point in time, there was a whole industry on that. And so we are at a point with AI of disruptive innovation. Now you can see where these might cross, where the standard technology and the disruptor, they sort of meet at a crossroads. But with AI, this is really much steeper, exponential type of curve that we're seeing. This is technology. It doesn't go at the same rapid pace. It goes at an exponential pace of development. And so when we look at where are we in time right now, where are we in history, we can't use the word we're at a crossroads. I say we're at the very, very top of a steep slope. Now, the Olympics has been on our minds recently. So here I'll say, we're at the top of the ski slope, right? We're already heading down at record speed. And how do we make things safer? We want to think about the guardrails. We want the guardrails in place before we head down the mountain. And we're in a position now where we're down that mountain, and those guardrails are really important. When guardrails are important, that's when we think about a term called rules of engagement. And so rules of engagement are rules that help us know in a very methodical way when we're going to do something, how, who is responsible for it, under what conditions. And this gives us that clarity before we have that speed. The other thing rules of engagement help us with, okay, now I'm coming to you as a neurologist, there's sort of two parts of our brain. One is that emotional part. It's pretty quick to act. And then there's a frontal lobe part, our judgment, that gives us some rules that keep our emotional brain in check. And so these are the rules of engagement. Now, in medicine already, we have rules of engagement. We're familiar with this. You've probably heard of HIPAA, rule of engagement, clinical guidelines, informed consent, our ethical standards, and some of the specific things that we have, the rules in place that help us deliver safe and ethical care. So for rules of engagement with AI, I like to think about what's a way that we can think of some rules of engagement. So I have 5 for you and a way to remember them. So I'll go through these in more detail. But number 1 is that judgment, sort of the ultimate decision maker, needs to stay human. Equity has to be right up front. Thinking about the equity, the ethics, as we are putting together our systems that we're using, has to be in the forefront. We want to name when AI is in the room, call it out that that's what we're using. And we want the guardrails before the rollout. And lastly, a culture beats the coding. So I'm going to tell you more about that, but this is the mnemonic here, is the Jenga. So with Jenga, it's not any one of those that will topple this great tower we're building, but it's a few key ones. And so for our guardrails that we're thinking about, we can use this Jenga acronym. So judgment stays human, right? We as humans need to sign off on what AI is assisting us with. This is one of these stories that you may have heard of before, and this is a schematic of how it happened. So this was back in 2016. There was a man who was driving a Tesla on the auto drive, and he had personally rigged a system that allowed the iPad to be hooked up and in front of him, and it was playing a Harry Potter movie, and he was going about 70 miles an hour. So he was not even looking at the road when that semi made a left turn, and that was a fatal accident. So Tesla, they like that title I have right at the top. Automation does not equal accountability transfer. But what they said is in the autopilot in Tesla, and all the cars they had on autopilot, they had already had 130 million miles before this fatality. Whereas if you look at just cars in general driving, it's a one fatality about every 94 million miles. So that's what they were looking at. But I'd like us to keep that in mind about how important it is, even when technology makes things efficient and we learn to trust it, that we still need to have that human oversight to what's going on. So when we think about AI in medicine, to people who are doing clinical care, what is the #1 tool that we're using? Open evidence. So open evidence, totally disruptive technology. Because before open evidence, what were we using? Up to date. Okay. Now, everybody is using open evidence. But AI, open evidence, it has something called hallucinations. It's not always correct, even though it says that it's only using content that was published in some of our top, most prestigious medical journals. It still hallucinates. So here's an example of that, where one of my colleagues was using open evidence, and open evidence suggested right in her note that she write this phrase here: the expert panels recommend interval MRI surveillance for migraine patients with incidental white matter changes. That is wrong. Actually, the correct version is on the left, that we recommend not doing routine MRIs. So even in an AI technology that many physicians, clinicians have come to rapidly trust, it can be wrong. It can have error. And that's where the human judgment is really important. We use another program, AI program, very commonly in treatment of acute stroke. And when somebody has a stroke, when they suddenly have a risk of brain damage from lack of blood flow to the brain, we can do rapid AI analysis of their brain scans to decide whether they need treatment and what kind of treatment we can give them. All of the neurology residents here know everything about this, including all of the problems with it. So just another example of how when you have a new technology, knowing the errors, knowing the rate, the risk of hallucinations, the rate and the risk of artifact, and also of errors in the technology. So just as an example of this technology and the error that it made, so here is a CTA looking at the blood vessels going to the brain. And you can tell on the left blood vessels, on the left side of the screen versus the right, there's a difference. And so this patient had a sudden onset of right-sided weakness. He had a blood clot in his left middle cerebral artery. And we do this rapid AI software. This came to the hospital within an hour. And what it showed in the purple, we usually think of that as the part of the brain that's already permanently damaged. And the area in the green is the part of the brain that we can save if we put a catheter up to that clot and we remove it. And if they look the same, we don't bother doing this. So they look pretty much the same, except for this error that rapid AI makes. And if somebody gets this brain scan really quickly, it will do something, we call it a ghost core. All the neurologists know that term, ghost score. It just means it's not real. That's not permanent damage. And in this particular patient, they knew that. And they took that blood clot out of the artery and he had no stroke at all. He came into the hospital paralyzed on the right side of his body, and he left the hospital with no stroke. And that's because human judgment was involved, and we didn't rely on the technology, which otherwise is super helpful. So going on to the E, equity upfront. So here I asked AI to give me an image of diverse faces forming a data grid. So again, AI's version of diversity. I will tell you, AI is not considering frowns as part of the diversity. But you can see some of the other problems with how you might consider diversity versus how an image generator might consider diversity. So when we think about equity up front, I wanted to share this story with you. And maybe some of you have heard of this Obermeyer study, which was published in 2019. And this was a program. It wasn't AI. It was just a simple program, but very commonly used to try to figure out who needed the most case management assistance, which patients were the most vulnerable, and might we give them extra help to help them stay healthy or get over their illness. And so what they did is they said, well, how do we figure out which people need our help the most? Let's look at the people that we spend the most money on. And those must be the people that need the most help, the ones that we spend a lot of money on. And so it was faulty logic. That program worked. It identified the people we spend the most money on, and it gave them more assistance. But identifying the most money didn't tell us who needed the most, because the people who needed the most didn't have access to healthcare necessarily, and therefore they couldn't spend the money on healthcare, just as Dr. Budhu was showing us those financial disparities and those barriers to healthcare. So we have to think about that equity up front. They didn't mean anything bad by it. They just used faulty logic. If they had used the correct logic, the Black patients would have received 3 times as many services as they did using the program with the error. So then we're going on to N, name AI when used. So we name AI. This is the top of one of my visit notes for my patient. It says that I used AI in the note. We can have disclosures before our talks. And then ophthalmology residents, or candidates for ophthalmology residency, their application says whether they used AI and how they used it. Many schools have the guardrails for how to use disclosure, how to name AI. This is an example for citing generative AI use from Stanford. Maybe your own schools have something like that. And then going on to the G, the guardrails before the rollout. So we want to have those in place. Those are our safety guardrails. So when we think about guardrails, those are really important. Those are the rules that keep us safe. Like when you go on a roller coaster and they put the rail in front of you, all right, that secures us. When we go and we kind of lift up on it to make sure it's still there and it's tight, we're not hoping that it lets loose. Sometimes we just want to know the guardrails are there. So when we build them, we want to make sure we have some oversight over them. So here's an example from Healthcare Executive, where they're talking about healthcare executives and how the majority of them don't have guardrails in place, at least at the time that this article was published. But I want to go to the bottom and also say, not only do we need those guardrails and we're trying to build them, but if we look at the bottom, it says one recent study estimates that AI could save the healthcare industry up to $360 billion per year if adopted more widely. So getting on to the next point, a culture should be code. So when we think about our culture and we want to use AI, what does our culture say? Right? we want to use AI to help people, to help take better care of them. Sure, it's important to save money, but we want that equity first, right? We want to think about how we're building that. And when we think about our largest EHR that we use, Epic, right? Epic, which does many remarkable things, but it was designed to help hospitals with revenue. And then when it was expanded for physicians to use it, it wasn't expanded with what we had in mind. So we're still really looking forward to getting Epic at Westchester Medical Center. But when we think about how we're using AI, it does concern me, as important as finances are, that that could come first when we're talking about healthcare. I think we need to change that dialogue. So we went through our 5 rules of engagement, Jenga. Hope that helps you remember them all. And I'm just going to end AI and medical education. This is where I spend a lot of my time, okay? How many of you are using AI? All of you. And when we think about building those guardrails, who usually sets up the rules, right? The older generation, who does not know technology quite as well, right? Very, very separate there. As a example of that, one of my colleagues said to me, her daughter said, "Mommy, when you were little, what apps did you use?" And that really gave her pause. She paused for a minute and then she said, "Outside." So young people really rapidly adopt this. The people who have more history typically set up the rules. So again, a little more neurology. The functions of the frontal lobes. The frontal lobes are all about judgment, reasoning, figuring out the rules. They are the last place in the brain to develop, and they are not fully formed until we're 25 years old. So evolutionarily, it makes total sense for young people to rapidly adopt AI, to use it all the time in all sorts of adventurous ways. But we have to put the guardrails in place, because young people, when they lift at that roller coaster bar, they don't want it to fly up, right? We want to build the guardrails there. So I want to say, well, what does the NYMC say about medical students? And they put together principles for use of AI, but I found it, I'm not going to read them, but what I found really interesting is the citation at the bottom of this NYMC website. An initial draft of these principles was generated using ChatGPT 4.0. So we are really embedded with use of AI. And I'm going to end going back to that patient story. So when I think about that patient who really had no memory of the time, but he saw that doctor and the doctor made him feel safe by his kindness. That reminds me that humans are not optional. We're necessary. We're necessary in everything. And we're at that really top part of the slope where things are rapidly changing. There's this accelerant, but we need to be at the steering wheel. And that is the rules of engagement. So humans first, still. Thank you very much. I'll say why you're thinking about your questions. If any of the visitors, the students here, want to make a comment, you are looking at things very differently than I am. So I appreciate your comments as well as your question.
This is a really wonderful talk, Dr. Milligan. I was curious on your thoughts about, you mentioned the frontal lobe. So with medical education, do you think there's going to be differences in critical reasoning skills, or how do you approach that when looking at a differential diagnosis? Do you think the way that physicians think or the way that we're taught to think, do you think that's going to change in the future?
So I think that's a great question. And I do actually spend a lot of time thinking of that. We don't need to teach facts anymore. the way we used to. We have to teach people how to reason, how to think through and use information. And so looking at AI as an accelerant, I think is the way to do it. So how can we use AI to help us build our clinical reasoning faster? At the same time, we need those guardrails that say, you know, you have to come up with your own independent thinking about this and not just type it in and spit out the answer that AI gave you. So it comes with the guardrails, and then also I think there's a lot of really great innovation in education and how to use AI as an accelerant of clinical reasoning.
Hi, Dr. Milligan. My name is Yasir, and I'm here with Macaulay Honors College. And I have a question with regards to how doctors can use AI in day-to-day care, especially inpatient care. I was at a conference last summer, and they were talking about how they use AI to prevent the possibility of a patient developing septic shock. So my question is, how can hospitals start using AI to teach their residents to use AI in a way to stop something from happening to a patient just by noticing tests and numbers that the naked eye can't really see?
Thank you. That's a really important question, because when we think about the benefits for computers, just straight programming, as well as some being able to use data to come up with new conclusions with AI, being able to harness vast amount of data, our EHR is designed to do that. There's a lot of people working hard on that, including sepsis, as you said, to pick up on these early warning signs and to alert humans to act on those early warning signs. So I do think that it's already here and has great potential to make medical care even safer. So really important question. The other thing that AI does is it can accelerate our communication skills too. And there was a recent article about how doctors are using AI to help them communicate better with patients. So let's say I have a really hard conversation that I want to share with a patient or a family member. I can rehearse that and get feedback with AI. So it can help us with our clinical reasoning, but could also potentially help us be better communicators too, and to get more real-time feedback in how we're communicating.
Great. I have a few comments and questions from the chat, from the Zoom, and I'm just going to go through them. One of them says, "Thank you for the wonderful talk." This is from one of our medical students. Given the current ubiquity of accessible free subscription AI models, how can we reconcile with patients or their family members in the event that they consult AI about their health concerns? How can we educate our patients on the limitations of AI while also avoiding paternalism in medicine?
Great question. Thank you for that question. When it comes to answering medical questions, I mean, you know, it's basically like Google. I mean, we've been dealing with this for a long time. It's better. I think it's somewhat better. And so now there's been a shift that predates AI of, instead of the paternalistic, where we tell patients things, we partner with them. That shift has already happened. And so I welcome more educated partners in this. And we've already been working through this, you know, with people Googling information. But there are examples, and I've had these myself, of patients who've had challenges, and they come in and say, "I think I might have this." And I was rounding on a patient. People didn't know what was going on. We did a lot of tests. Finally, we came up with the diagnosis. And she said, "Yeah, that's what AI told me. That's what I thought I probably had." Well, she was right. So
I'm going to go through these real quick. The next one says, "The 2030 workforce skills research shows reasoning as a high priority in our future workforce," which is what you were commenting on, the importance of that. And then the last one I have is from an anonymous attendee. It says, "Great talk." And they comment, "There are many older, quote, physicians who are far more adept with current technology than young students. At 84 years of age, I challenge any young students to top my ability to use technology."
yes,
I heard we have all the students here in the audience.
respect. But I'm telling you that 84-year-old is not going to take the same risks using technology as, you know, that's evolution. Young people take more risks.
We'll take those last two questions, and then we'll we're gonna move on to the next talk.
Hi, my name is Edith. I'm also with the Macaulay Honors College. And so just from like personal experience and like towards communities that have experienced medical discrimination and have distrust in the healthcare field because of it. And I was wondering how might like AI affect that trust in those communities? And would they trust AI more since it's not human and accelerate that trend? Or do you see like a shift where they trust the doctor more because it's not human and value that emotional connection with the doctor more?
Thank you so much for that question. It's such an important question. I wish that AI would fix mistrust. If it could accelerate trust, and it has the potential to do that, that would be great. But we already have examples of technology that has magnified problems. And so I think we have to be very intentional. That can be one of the things that intentionally we go in with the E of the Jenga, with thinking about equity, and as part of that, the trust, and then to label AI too, so that we're very open with patients. I think about that every time I turn on my AI scribe in a doctor's visit, that we're consenting our patients to the use of this. We're making it known that we're using this technology and making sure that we think about equity and that we label what we're doing and build in that way. Hopefully we'll be able to help with some of those challenges that you brought up.
Thank you.
Okay, last question.
Hi, I'm Vanessa. I'm also with Macaulay. We were this was mostly about like doctor-patient interactions with using AI as an accelerant, right? But I was kind of thinking about the fact that usually like with patient care, it takes a team of doctors from different kind of professions and different perspectives, right? So since we were talking about like communication and how AI can facilitate that as well, might AI also have a role kind of in doctor to doctor or like within kind of the healthcare environment, those conversations?
Thank you so much for that question. It's such a great question. We need that. We need exactly what you are asking, whether AI can help us with that. Because we are all looking at a patient from different angles and different perspectives and through different lenses. And it can be very narrow. And to have something that can synthesize that information and opinion to help our patients, I think that's something to really look forward to. So I hope that happens more and more. Thank you.
Excellent. Thank you very much, Dr. Milligan, for an outstanding keynote address. We appreciate that.
So I have the great pleasure of introducing Dr. Adam Block. He is an experienced applied health economist and has deep experience in digital health, consumer choice, and insurance benefits and regulations, and healthcare costs. He has worked as an expert witness testifying cases across the United States and has spoken internationally on health economic issues and consumer choice. Dr. Block's research focuses on evaluation of telehealth programs in the wake of COVID-19 pandemic, price transparency, cost sharing, plus supporting all of his doctoral students' research interests. So without further ado, I'd like to introduce to you Dr. Block.
Thank you. All right, so I'd like to thank Dean Schluger, Dr. Etienne, and the entire conference committee for inviting me. I'm really excited to be here. When I first got invited to come, Dr. Etienne asked me to talk about, well, quite a few things, actually. It was telemedicine, and he's like, well, and there's a lot of things going on with Obamacare right now, and there's a government shutdown, and there's a couple things going on in New York State, and there's a lot of drug policy, and you've got 25 minutes. So luckily we're in New York. We are New Yorkers and we talk quickly. So we're going to try to get through as much of that as we can. So what I'm going to start speaking about is the impact of digital health services, but really the impact of COVID on telemedicine and where telemedicine came from and where it's going. And my background is that I am not a physician. I'm an economist, right? And thank you for not booing. So what that means is the lens that I look through with all these things is less, it'll be a little bit quality of care and clinical care, but really from a population health perspective, but mostly from a cost perspective, and also from like a DC funding perspective, which is like, this may be better for patients, but if it costs more, where is the money going to come from, right? And so that's really one of the bigger questions in telemedicine. Telemedicine has been around for like a very long time, right? However, the issue was it never got funded until we had a moment to fund it. So before COVID, there were very limited options for virtual care. Why? Because Medicare wouldn't pay for it. And basically, commercial health plans generally do, they don't have to, but they do what Medicare does. And so there were very few options to do it because Medicare was driving the policy. So what we saw was that patients were traveling long distance for routine care and some of it could have been virtual. Some of it couldn't have been, but some of it could have been. But after the CARES Act of 2020 and the CMS 1135 waiver that expanded the access to virtual care basically to any specialty, that was, of course, only driven by the fact that everybody was told to stay at home. And if you were going to a hospital or to a provider's office, it was really for care that really could only be done in person. I remember this firsthand, which is I had a 7-year-old at the time when COVID happened, and he was walking on the top of our jungle gym. And I was like, you cannot do that, because if you fall down, we are going to fix your arm with duct tape and a stick, right? We didn't want anybody, right? Because you wanted to save the hospital beds for people that like really, really needed them. What we saw was that there was a 766% increase in telemedicine in the first 3 months after the pandemic. A couple of the key takeaways were that providers really like it when there is an opportunity to do it appropriately. What we see from a financing perspective is that, and anybody that has done an urgent care visit in telemedicine, you sit at home, right? You sit in a digital waiting room while you are waiting for your provider to come on. The provider comes on, and when you're done, you close the link. That takes the time from, right? That reduces dramatically the amount of time it takes to see the provider. And so for things like when you have an urgent care visit, for an earache that may be necessary, may not be necessary, people are frequently willing to do those visits. And providers, now that they're being funded for it, are also willing to do those visits. So there's a brand new opportunity for those things to happen. Now, what that means is that, and in addition, what we see is that there's been a dramatic change in the amount of telemedicine that's been used. 35% of physicians report daily use, and NPs are performing it as well. One thing I want to talk about is that, well, I'm going to skip this slide. We're going to come back to it. I want to talk about public policy and over the last 10 years, which is that telehealth previously, before really 2017, was only reimbursed for rural beneficiaries in unique sets of circumstances. And then we had the 2020 emergency. The question was, what happened after the public health emergency, right? Public health emergency had to end at some point, but people really liked it, both patients and many providers. The issue was the cost. Now, why is there a cost associated with telemedicine? Anybody think of why there would be a cost? Shouldn't it just be a pure, what I would call a pure substitution? That's why people don't like economists. A pure substitution is, well, I was going to go to the office visit, and now I'm not going to the office visit. Well, what we see happening sometimes, not all the time, is that you have the telemedicine visit, and then during the telemedicine visit, the provider is like, well, now you need to be seen, because we were able to take care of some of what you wanted, but not everything that you needed to be seen for. So then you get seen the next day, the next week. So it actually was an addition in the amount of total visits that were occurring for some patients. In addition, The ease of access made someone like me that was thinking, well, am I going to take my kid for an earache? Well, I'm not going to go drive in the snow at 8 o'clock. I'm going to roll the dice and see if they get better tomorrow. Or now I can go see the provider by clicking online and getting to see a provider at 8 p.m. for a 15-minute visit. Financially, that costs the same amount of money, right? So telemedicine is actually, while there are savings, it is a net cost. And so that is the reason that congressionally, there are broad concerns about continuing to expand it. What most of the telemedicine advocates would really want to see is they want to see this being done permanently. This is now a new part of medicine, right? We had an experiment that none of us wanted, which was the COVID period, right? That showed that in a lot of situations, this works really well. It is better for patients and it can be better for providers. But what we are seeing is that the costs are prohibitive. And so what we see is Congress does what Congress does best, which is it hedges. It says, well, we'll extend this for a little bit longer. We'll extend it for a little bit longer. And so with that, they tend to, that's where we are right now, which is the current state. Medicare telehealth got extended. My understanding was, I think it got signed into law like February 3rd, like this week or last week, with an extension to 12/31/2027. My friends who are telehealth advocates they wanted a permanent extension or a permanent change. They were pretty happy because prior to that, it was happening month to month. Okay. Maybe I'll take a moment and just go back to this slide. What we've also seen happen, and we've seen the rise of, I think AI is part 2 of a digital change that we've seen happen in the last 10 years. Part 1 was the application of the creation of apps that treat every sort of chronic disease that you can ever see, right? And we saw this advertised on the Super Bowl, right? With Hims and Hers doing tons of advertisements. But there are all sorts of diabetes care apps. There's chronic kidney disease apps. There's apps for mental health. Prior to AI being a major factor in this, there have been Talkspace and other apps that were involved in this. And so this has dramatically changed the overall landscape with people doing more towards self-management of their care. I work in this space pretty extensively, and we talked, I think, earlier about does this stuff, right? We should have an evaluation of whether some of these things works. And there's an organization out there that focuses on this area called the Peterson Health Technology Institute. It's a foundation-funded organization. And what they do is they look at all of these apps in different areas one at a time and say, is it improving clinical care? Is it saving money? It works on the evaluation is essentially done on behalf of the consumer saying like, is it going to save you money in the long run by engaging in this app? What I'll tell you is that, because I've read all of these reports, there's about 10 or 12 right now. There's a handful that do and there's a handful that don't. The ones that do, the common theme that I see is they are substitutes for care in terms of saving money. So an example of it is, has anybody heard of Sword? So Sword Healthcare is a physical therapy app. However, they send a little suitcase to your house, and that suitcase has basically a device that goes on top of all of your tapes to your arms and your legs, and then you engage in physical therapy. And there's an AI physical therapist that watches you engage in that. That works to do substitute in lieu of physical therapy, right? And so you're not paying for the price of physical therapy and for the app, you're basically just paying for one or the other. Others that work on top tend to focus on trying to improve prevention. And while they're generally a little bit successful, they tend to not save money in the long run because it's just something else on top of your regular care. Okay. So what happens next? I mean, I think we wait and we see, continued Medicare telehealth flexibilities, whether they get extended, but they're currently extended. Okay. So let's talk about updates to the Affordable Care Act. So the Biden administration engaged in quite a few changes to the Affordable Care Act. And a couple of them were basically, and that is the source of the government shutdown that happened in the fall, right? Which was that the Trump administration then did not want to change. They didn't say we are going to get rid of the Affordable Care Act. They said that the Biden administration changes were temporary, time has run out, and we are not going to re-extend them. That was what the fight was about that caused the government shutdown. I just want to clarify, like that was the cause. Now, what was in the Biden changes? The Biden administration changes were a couple of things. The first is that people in the Affordable Care Act, it was only supposed to provide you there's a couple of ways that people get health insurance in the United States. One is Medicare, one is Medicaid. Medicare is for people over 65. Two is private insurance, which is for basically people that are employed for the most part. Three is Medicaid for people who are generally unemployed or underemployed. They don't work enough hours, or they don't work for a job that offers them health insurance. The exchanges were created for people who are really self-employed. They don't work for a small employer or a big employer. They work for themselves. And if you are making $30,000 a year or $40,000 a year, and health insurance costs 5 or 10 or 15, or for a family, 20 or 25, it provided subsidies to help you pay for that while maintaining your job as a self-employed person. What happened was it was capped at if you made over 400% of poverty, which is $125,000 a year, you got nothing. And so the Biden administration said, you shouldn't get nothing. It should just taper off. And so that was one of the switches that they did. They basically tapered it off. And another was there was an expansion of the subsidies about 10 or 15%. In other words, they increased the subsidies about 10 or 15%. Those were really the two fundamental changes that happened. So then the real underlying question is, well, did more people get insured? Who got insured? As a result of this, what actually happened to the number of people who are covered in the exchange market or in the private sector overall? And really the number that I want to know is, what happened to the overall uninsurance rate? What I'll tell you overall, and I cut my teeth working on Capitol Hill, helping draft sections of the Affordable Care Act, back 15 years ago, more than 15 years ago now. And what we saw initially happen was that the uninsurance rate in the United States went from about 14% to about 9%. And so what we're seeing here is shades of 1 or 2% of the population becoming insured or uninsured between the Biden and Trump administrations. So I don't want to overstate how impactful this is, meaning we're only talking about a couple of percentage points of the population for which this is impacting. But what we saw was that the boosted premium tax credits did expand enrollment. And we saw that people went from about 12 million pre-Biden administration to being in the exchanges to about 24 million in 2024. For a couple of different reasons. And in addition, Dreamers became temporarily eligible to receive subsidies. So this is a graph that I would show and shows that it's from Kaiser Family Foundation, which does, I would say, the best research on all of this in terms of counting the uninsured and counting the uninsured. A couple of broad brush changes of what happened after the Biden administration in the second Trump administration. And so the thing that I want to talk about just briefly is that the Big Beautiful Bill's fundamental change is happening really in Medicaid. And what it's doing in Medicaid is actually extraordinarily hard to A, quantify, and B, discuss. So I'm going to try to explain it. There are no, right? Medicaid basically says for the vast majority of states. If you're under 138% of the federal poverty line, which is like 20 grand a year, right? Then you're in Medicaid. And if you're over that, you're not, right? And there's a hodgepodge of different options for people that are over it that might be able to get enrollment, but really you're either in it or under 138 or you're not. And what the Trump administration did with the Big Beautiful Bill Act in June was they said there are now going to be work requirements to be in Medicaid, right? They did this actually during the first Trump administration, and it rolled out in, I believe, Arkansas and a couple of one or two other states. And what ended up happening was it increased what we call the paperwork burden, which means that to enroll in Medicaid is already very hard because you have to prove that you don't have money. You have to prove that your income is low. You also have to prove that you don't have assets, right? Because my grandmother's income is really low, right? But she lives in a $2 million house. I'm making this up, but like she lives in a $2 million house. So you have to prove that you also don't have assets. Then all of a sudden you have a bunch of other things that you have to prove, right? As well as now one more thing, which is you have to show your pay stub every week. And if you don't show your pay stub every week, then, or that you're going to school or that you're taking care of somebody. And if you don't show one of these things, you're out. So the Congressional Budget Office scored this as eliminating 5 to 10 million people from the Medicaid rolls, and that is where the savings is coming from. So it's not actually changing the rules, but it's changing what we expect will actually happen. And so that's the impact of the Big Beautiful Bill on overall Medicaid enrollment. Hospitals are gearing up for this, meaning like they know that there's going to be fewer people that are insured, and there are going to be fewer insured people coming into their doors, and that they are going to have less money, right? And there was a question earlier about prices and talking about, why are things so expensive? And the example that I want to give is that like while hospital prices tend to be very expensive, if you look at what is considered a healthy margin at a hospital, I'm digressing a little bit, but that's okay because I'm the one up here. So if you want to look at what is considered a healthy margin, it's usually, and this is by all the folks that lend hospitals money, 2%. So that means if you're a hospital and you make $1 billion in revenue, that means you pay out $980 million in expenses every year. So that is not a lot of wiggle room that these guys have. So it's not like there are piles of money that are hiding in the hospital somewhere. Okay, I'm on to my last topic, which is New York State. So I wanted to talk about this because I get Crane's Business Review every week. And usually there's a little article on healthcare. And in this week, it was a big article on healthcare. And the title of the article is, so I was like, well, you can't get more timely than this. This showed up at my door like 2 days ago. Assembly Health Chair Amy Paulin on the biggest challenges facing New York healthcare. So a couple of the biggest changes are first, Medicaid work requirements, right? Which is what I was just talking about. And these are some of the specifics. That beginning January 1st, 2027, that anybody 19 to 64 has to document 80 hours of work per month to maintain their eligibility. And the expectation in New York State is that 500,000 to 1 million people lose coverage as a result. Then there are additional immigrant coverage restrictions, which is that lawfully present non-citizens are further restricted in their ability to get Medicaid or CHIP. And then the last thing is this weird little New York State nuance, but it's just a great program that I believe only New York State and Minnesota has. And it's the Essential Plan, where people that are between 138% and 200 or 250% of poverty can get access to free plans in New York State. And they are going to reduce the number of people that can basically, the budget cuts are going to reduce the number of people that can access the Essential Plan. The second to last thing I'm going to cover is this is what people in New York State are worried about. New York State has something called the Managed Long-Term Care Program. And the Managed Long-Term Care Program we've had since 2012, and there's a bunch of fraud and abuse. And then the last thing is she got asked this, and so I'm going to answer it. The question was, is there any interest in psilocybin in New York State? And the quote was, it does seem to work for many people who have mental health issues. So I'm very much in favor of trying to get something done this session. I wasn't expecting to hear that or see that, so I thought that was pretty interesting. And then the last thing I'll say is that, if you want to learn more about this, I teach at the School of Health Sciences and Practice, and, come ask me about our programs. Thank you.
Are there any questions?
There's no question. I have a quick question, Dr. Black. I'm sure you heard earlier, one of the students asked Dr. Budhu a question about how the hospitals, charge large amounts of money for simple things like administration of acetaminophen. Given those small margins that you've indicated, is that a factor, you think, of why they're charging such high prices for things that we can do on our own at home?
Oh, I love this question. This is a great question because what you see now, and we are in and I just talked about a whole bunch of differences between the Trump administration, the Biden administration, and the Obama administration, but actually there's one common thread that we have seen in the last decade or two, which is a dramatic improvement in what I would call price transparency. And so what we're talking about is charges, and that's the amount in these charge master rates, which are something that nobody pays. But what is paid is an actual negotiated rate between Aetna or Cigna, a United and Westchester Medical Center, and those rates tend to be a lot closer to costs. But they can be dramatically different across payers. What you see and what we have seen over time is that price transparency has shown us that different payers may pay very, very different rates than what Medicare is, 3-4 times as much. Whereas if you were looking for a car and a car costs, manufacturer's price is $25,000, if you're a good negotiator, you could probably get it for 22, maybe 23. In hospitals, something could cost one person $10,000 and another organization $50,000. You just don't see that in other areas, that dramatic price differentiation.
Thank you. And can you comment on comparing a typical hospital to places like Kaiser and Geisinger, where the insurance plan also provides the healthcare?
Sure, I could try. I think the cost bases of virtually all of these hospitals are relatively similar. I think that the margins that you see reported from all these hospitals, they may range from -1 or 2, meaning they're losing a little money for the year, to 5 or 7. Nobody's making 35% the way that some tech companies are.
Zoom. Actually, there's two comments. One is, what would be your take on the impact of upcoming restrictions on Medicaid's enrollment? Is there any tendency to pivot this law after the midterm election?
Oh, well, so first, I like the discussion of the midterm election. It is not a coincidence that this law goes into effect January 1st, 2027, and the midterm elections are November 2026. That was very much done on purpose. They don't want to throw a whole bunch of people off of Medicaid right before an election. Is there a chance to change it? I mean, probably not, right? Because in order to change a law, or write a law, you have to have the House, the Senate, usually close to a filibuster-proof majority in the Senate, and the president has to sign it into law. So even if you were able to flip the House Democrat, which there's a decent chance of, the Senate, which there is a slimmer chance of, but is possible, the president has 4 years in office. So I don't think that's, in my opinion, that's not changing so fast.
And the last question, this is from Dr. Vilazane. Thank you for the great presentation, Professor Block. Looking at the combined effects of ACA subsidy rollbacks, Medicaid work requirements, and the potential loss of the essential plan in New York, do you see these changes primarily as a federal retrenchment problem, or as a test of how far states like New York can realistically go to backfill coverage losses? Where do you think the limits of state-level policy actually are over the next few years?
Dr. Vilazane? Yeah. Hello, Bruno. I thought you were going to give me a softball, and you definitely did not. So Dr. Bolesny, my answer to your question is I think my experience on Capitol Hill is that people are trying to basically get right, like bills have to be balanced in terms of their expenditures. And I think individuals that want, let's say, reduction in tax credits, like they are trying to get that reduction in taxes through the cheapest method that they can do, or by impacting populations that they want to impact without harming other populations. I think that this bill was basically designed to reduce spending in the healthcare sector. And I think it's going to be pretty effective at doing that by reducing access to care. And that's the methodology by which it's doing it. So I think it's having its intended effect. And the states are having to figure out how to fill in some of those gaps. Thank you.
I would like to invite our chair of OBGYN, Dr. Sean Tajarati, to present the next speaker.
Good afternoon. Thank you again for having the conference, keeping this focus and bringing everyone together and advancing this on a yearly basis. This is a really poignant moment for me to introduce the next speaker. Dr. Trotman, when I was thinking about our Center for Women's Health Equity, which was started here in 2023, I couldn't imagine that a few years now, we've now secured almost $1.5 million grant from the state of New York, had significant changes in the actual clinical outcomes of pregnant women who are in high-risk categories in this region that we serve. And as a result of that, we reduce one of the markers, which is primary C-section rate, from about 40% to about 15%, which led us with multiple other things to really think differently when we put the patient at the center. The entire hospital and the system was for the first time, marked on U.S. News and World Report. So it's a wonderful accomplishment that's resulted out of this. The reason that I say that is that when we put patient and health equity and access at the center, we actually have very measurable clinical results that follows. So it's not just some pie in the sky for particularly to students. If you put it as the basic of your mission of your career, it actually has significant impact on what happens to patients. To that end, I've been always thinking about who are some of the key people who could actually be leaders in that Center for Women's Health Equity, not just at the medical center, but at medical school. So I happened to be in Dallas as a board examiner for the American Board of OBGYN. And who do I get paired up with than Dr. Trotman? Much to the dismay of Dr. Trotman, much to my pleasure. So we worked together that day. And during the entire day, I said, my goodness, wouldn't it be wonderful if she was a faculty here? And wouldn't it be wonderful if she had a role in the Center for Women's Health Equity, knowing that we really wanted pediatric GYN and adolescents as a serious area of our need to address those. So I was bold enough at the end of the day, I mean, perhaps somewhat idiotic enough, but bold enough at that moment to say, you know, I think we'll work together one day and I'll try to recruit you. And she kind of pooped it off and went. And, you know, once in a while, you make the right calls and you make the right bold moves. And I could not be happier and more proud to stand here as a partner of Dr. Trotman, who just joined us in December as assistant chief of our pediatric and adolescent gynecology at Westchester Medical Center. We stole her from Mount Sinai. She was an associate professor there and division director. She's now a program leader. She's now coming in here as that and also really investing herself in larger roles within the medical school and more importantly at our center. She has an impeccable, not just academic, but clinical following and history in pediatric and adolescent gynecology. You can imagine what an area of significant disparity that is for it. And we're going to really talk about health access, her specialization in children, adolescent, and complex gynecologic conditions. Her clinical focus is on chronic pelvic pain and improving access and optimization of patient experience. She's held leadership roles in a variety of different Center for Health Equity here advancing our quality improvement and education. And you have no idea what a fabulous decision I made until you hear in a couple of minutes. So it is my total pleasure to welcome Dr. Trotman.
Good afternoon, everyone. I know this is right before the break, so hopefully we'll get through this without too much sleeping. This is going to be clinical, and I'm going to spend some time going over some background. So thank you, Dr. Tedrati, so much. I am the Chief of Pediatric Analysis and Gynecology here, although I will be speaking to general OBGYN, not teen specific. And hopefully at the end of this, we have some budding OBGYNs. So hopefully I'm able to convince some people. Make sure I have the right one. So I have no relevant disclosures. We're first going to describe endometriosis. So today we're going to be speaking predominantly about the disparities in care among endometriosis. And before we get started, it's good to give a little background just to discuss the impact of that disease for those who may not be aware and those who may be aware and also struggling. We're going to examine some structural inequities and how we got to the place we are with the disparities, and then we're going to identify our new rules of engagement. I do want to spend some time just to acknowledge I will be using girls and women throughout this talk, really because it's based on how the literature is, but I do want to be inclusive that endometriosis affects potentially all persons with the uterus, regardless of their gender identity, as well as many, many marginalized groups. But we will be centering today on the Black woman's experience. So what is endometriosis? So it's basically a chronic inflammatory condition. I think most people would have a person in their life who struggled with pelvic pain or menstrual cramping, and a large proportion of those people would have this disorder. It's basically when tissue that should be on the inside of the uterus is on the outside, and it's located in places that where it's not supposed to be. Because of that, it causes a local inflammatory response that then goes systemically. It is the leading cause of secondary dysmenorrhea, meaning dysmenorrhea or menstrual cramping that has a pathologic reason. It's not cancerous, but it does have the potential to spread and infiltrate and damage other organs as well. So although we don't think about it particularly as a cancerous lesion, it acts pretty similar in some cases, and there is some increased risk of certain gynecologic cancers. There is no real clear etiology as to what causes endometriosis. There's a lot of theories. So even with all the technology we have, the best we know is that we have theories. The retrograde menstruation, or menstruation going out of the uterus into the ovary and into the tubes under the pelvis, is the most common. However, it doesn't make sense if you think about some people can have endometriosis in the lungs. So there's just a variety of theories there, none of which have truly been proven. And the main thing with endometriosis is that although it's mainly a pelvic disease, it really has implications for pain outside of the pelvis. So you truly have changes in brain chemistry, which then results in people having hyper pain syndrome. So you may find people with endo also having migraines, chronic abdominal pains, otherwise fibromyalgia. So it really is a full body thing with true changes at the brain level. So what does this look like? Although we think about it primarily as diseases of the pelvis, I want to be clear that people could present with a variety of things, including fatigue. You may have someone that comes in with poor sleep patterns, with more GI symptoms, with more bladder symptoms, and the answer could be endometriosis. So one could imagine this makes it really difficult if we're trying to identify something that has no one clear diagnostic factors. Even confusing situation even more, what's the prevalence? So we actually don't have great prevalence data worldwide for endometriosis because the way you treat, the way you diagnose is through surgery. But our best estimates puts it at about 10% of the general population, maybe 190 million people worldwide, probably more. But we do see it's more prevalent in different communities. So amongst women who are struggling with infertility, it could be as high as 50%. And among adolescents or teens that are struggling with chronic pain of the pelvis that doesn't respond to medication, that can be as high as 75%. So it really matters which groups you're looking at if you're going to decide what the prevalence really is. The impact you could imagine now goes just outside of having a menstrual period or menstrual cramping, and it impacts really all aspects of life for that individual as well as their families. And the economic impact of endometriosis, both from missed school days and missed work days and missed quality of life, could be in excess of 100 billion annually. And again, this is probably an underestimate because we're not sure what the true prevalence is. So it's a problem. Slide. So gold standard, so this is a laparoscopy showing how we perform surgery for endometriosis. We put a camera in, we take a look at the pelvis. This pelvis looks really clean, but this is a team with endometriosis actually, just to show how hard it is to find. You go and you do surgery and you can see endometriosis in different ways. It could be very obvious. You see there's like chocolate coming out of a cyst on D, or it can be very, very scant, as you can see in the first picture A. You can also have a lot of adhesions, and you can go in and find something like this, which is a little bit more obvious. And for my demographic or teen, sometimes you go in and everything looks perfect, and you see just small vesicles there that often go missed. The diagnosis does require, technically or traditionally, you take a portion of tissue and you look under the microscope and you see endometrial glands and stroma for diagnosis. So after diagnosis, that is only the beginning. We have to put our heads together. Because it's a multi-system syndrome, you really have to go at it from a multi-system way, including diet, exercise, physical activity, medications, and surgery as well. So that is just tip of the iceberg. And the issue with endometriosis is that you only see so much, and many people get diagnosed without any of the treatment. What makes it harder is that there's a lot of times diagnostic delay. And with the delay, you magnify everything we mentioned before. So the core with endometriosis really is early recognition, diagnosis, and treatment early, which then reduces a lot of the quality of life disparities that we see. It is a challenge, and it often takes up to 7 to 12 years before a person is diagnosed with endometriosis. So if we think about what that means, many people are actually having experiences of endometriosis as a teenager, as an adolescent, and it's going missed. And it takes an average of 7 physicians before a woman is diagnosed with endometriosis. And this is all comers. So what we do see, though, is in the last 5 to 10 years, we've had a lot of research into endometriosis and saying there's more money going there saying, hey, we really need to have advancements because this is impacting us significantly. And we are actually seeing really good advancements. We're seeing there's more education and information about endometriosis. The use of AI is generating, I'm going to spend a little bit of time on that in the end. Imaging, we're trying to find tools that doesn't require surgery to diagnose endometriosis and tools doesn't require it to treat as well. And the studies do show that it's taking it from an average diagnosis of 7 years down to about 4. Still not great, but we're at least moving in the right direction. So as we could imagine, endometriosis it has disparities for all comers, but Black women are amongst the highest group that has the most disparities when it comes to this disorder. And the main thing is a lack of awareness that this group is disproportionately impacted by it. So if you go on Google or do any search, you're going to find a lot of articles that speak to this experience of Black women continue to receive poorer care for the condition, endometriosis. Black women are being gaslit in the doctor's office when it comes to endometriosis. And this is not just limited to studies within the US. You actually see this worldwide, particularly in Europe as well. And it begs the question, why do we feel there's this systemic neglect? So I just took a few of the voices that we had from both Black women with endometriosis, providers, and researchers that came together to try to figure out what's really going on. And you see some of the same verbiage. You see young women feeling that they're hypersexualized, so they're more likely to think pain is due to infection. You see researchers saying, I tried to find research on disparities, and there was no research on disparities. And then you're just finding women saying, put the burden of being a Black woman on top of another burden of having pain that no one's listening to. And this goes on and on and on and on and on. So we really want to take a look at, well, what is this barrier? Like, how did we get here that women are struggling? So the first thing is the myth, endometriosis is rare in Black women. And I would say this, I trained not that long ago, I was in you guys' shoes, and I learned this in training as well, that it was not a disease that we saw represented in Black communities. And the reason is multi-pronged. So let's just take a little history lessons into endometriosis. So studies now, if you look at literature now, this is even in the 2020s, you'll find prevalence of about 6% for Black women, which we know is an underrepresentation just from what we're seeing clinically. So historically, endometriosis has been known for many, many years before the 1920s. But in the 1920s, within the United States, there was a significant decrease in birth rates. And Dr. Sampson, when he came up with the retrograde menstruation, he thought this must be due to, he saw that in affluent women. And Dr. Meeks, he actually thought it was due to contraception amongst people who were more affluent. And looking at studies on the ward, he said, okay, women who were thin, who were affluent, private insurance, white women, these were the only women getting endometriosis, and everyone else had pelvic inflammatory disease or fibroids or something else. Over the next 50 years, you found studies that basically looked at the population and had a significant selection bias, and they just perpetuated the same incidence report. Although you did have information that came out before then really saying, actually, we're finding the similar rates if we look at the right population. This picture here is of Dr. Chapman. He was the first gynecologist in the 1970s to actually look at his population significantly and find, actually, he's getting rates of about 20% amongst symptomatic women with endometriosis, which is about what we see in the population. So he did laparoscopies on almost 200 women, and found 21% had endometriosis, and 40% of those were previously diagnosed with pelvic inflammatory disease. So he basically started advocating, hey, let's treat Black women like we treat every other woman with endometriosis. And he also found there was no difference in parity, in pelvic pain, how they're presenting, both with infertility and pain, as well as where the endometriosis was. Unfortunately, the bias was already done and the deed was already done. And many textbooks, including textbooks I learned from, continue to perpetuate that this was actually very rare in Black women. And there was a pivotal study after the 1976 study from Dr. Buttram, who was one of the leading people in the 70s and 80s on endometriosis, that says, typically our patients with endometriosis appear to have an intense desire to excel. They are usually well-dressed and have trim figures. And this is what you're finding in medical literature there. So, it goes without saying the issues with that. So in the interest of time, I just want to go over what we know now about disparities, that Black women are 50% less likely to be diagnosed with endometriosis. They're an average get diagnosed almost 3 years later. And they have amongst the longest waiting time to diagnosis. There was a study in 2025. Most of the research is coming out now, 2024, 2025, which is great, that is actually now showing this. And one of the studies showed that women with higher BMI, despite popular thought, actually had a longer time to diagnosis as well. So no surprise there. There was an abstract that came out in November at a recent gynecologic study that shows among symptomatic women. So again, they're looking at a very defined group. The rates between Black and white women were the same, about 50%. So if you're looking at in the right place, you actually would find similar numbers. So first myth of Black women not having endometriosis, we know that to be incorrect. The second one, Black women are less susceptible to experience pain. And this is where you have the breakdown in provider and patient relationship with how people are presenting and how doctors or care providers kind of deem that pain. So there is well-documented history of the differences and the thought of biological differences in pain amongst Black people, and there is a false fundamental belief that biologically people of Black experience pain differently. There was actually a study that came out in 2016 and looking specifically at medical students who had a true belief that there is a biological difference also were more likely to rate Black people with pain at less pain numbers. So it does show that if you come in with bias, you actually perpetuate that in your care. And the opposite is true. People who had a lower biological belief, they were either likely to either rate it the same or actually give Black people a little bit higher pain scores. So, we know that there is difference and bias that people are actually bringing into their medical care. So what are women saying? So there was a qualitative review that came out last year looking at 30 Black women diagnosed with pelvic pain, trying to get a sense of where do you think the breakdown is, right? So a lot of people question, well, maybe is it a knowledge gap? This quantitative study showed that many women understood pelvic pain. They were even able to use complicated medical terminology and recognize it in other people. The real issue came with them feeling like there was a need to always self-advocate for yourself or fight for your care, but most importantly, the fear or the experience of being dismissed. And the number one group that dismissed really was providers with the highest frequency. And this is providers dismissing more than family or themselves, even social. So as far as if we're looking at women who actually do get care, women who are then able to get surgical care are actually less likely to have minimally invasive surgery, which we know has significant impact. So they're more likely to get larger incisions. They're more likely to get perioperative morbidity or mortality, so more likely to die after surgery or get a major or minor complication. more likely to have an ovary removed even at a younger age. So amongst women in their 20s, they're 3 times more likely to have an ovary removed. And they're also more likely to undergo a hysterectomy that was deemed inappropriate. The main reason we think this is happening is because Black women have been shown to have a less referrals to see endometriosis specialists and to get specialty care. And when they do get into the centers, they actually are more likely to get hormonal management, pain management, and surgical management, and the outcomes are about the same. So the disparities in the referral to the surgical centers or access to surgical centers is probably what is causing a lot of the disparities in surgical outcomes. As far as representation in research, as we could imagine, if the thought historically was that we didn't get endometriosis, then you have very little data to support the prevalence data. So this is just 2 tables I took from 2 systematic reviews. The first is on prevalence data, and there's only 3 studies at the time of this that actually looked at true disparities in care. And if you're looking at surgical outcomes up to today, there's only 4 studies. So within all of the incidence data studies that we looked at, the average prevalence is about 6%, with some studies being as low as 0.5% representation by Black women. And this is the same we're seeing in teens. So it's not even of value to use the studies within a demographic that's not represented. Outside of endometriosis, this really speaks to what's going on in GYN in a broader scope. And we basically see in most of the indices that Black women are disproportionately affected by worse outcomes, including maternal deaths. And Dr. Tedrati did a good job at mentioning the great work that we're doing within our center to combat some of that. So where do we go from here? We have 5 minutes. Dr. Tedrati took some of my time, so I should have 3 more minutes. So where do we go from here? So it's not all doom and gloom. We do have some new rules of engagement. And I'll tell you, what is happening is that a lot of people are turning their backs from medicine. And I think some of our presenters before gave great presentations showing a lot of the issues, and these are leading to barriers. So how do we reduce disparities? I don't believe it lands in doing more prevalence work or more work on how much numbers. We know it's here. We actually have to disrupt the systems. We have to retrain our healthcare providers. And it's really great that many of you are here because you're going to hear this early in your medical career. So now you'll take this with you and maybe avoid some of the biases and you'll teach one. And we have to also decentralize. Not everyone can get to these certified centers. So bid for telehealth, we need the experts to be able to get to people where they are and redesign our systems. So for the medical community, this can be a whole presentation on its own. We need a big call to action within ourselves. I think we first must acknowledge the history, and I put it on one slide, but it truly could also be a conference of the systemic racism and bias that has gone into a lot of the care, particularly in GYN. So that has to be acknowledged, and we do need reform for medical education. That's going to take time, and I do believe that as long as we're able to check our biases, people can still give good care. We also have to engage with advocacy groups, and we do need better ethical representation in research. So that's for us. This is the fun part. So what are people doing? So I'm adding myself 3 minutes. Representation in research. So we do have data out of Massachusetts that worked with a community health organization group, and they got a grant for patient-centered outcomes research. And they actually put together patients, providers, researchers to come up with a roadmap to say, okay, what do we do? How can we get better research? And listening to all the stories, they were able to come up with 6 proposed areas for research, and none of them involve incidence data. Basically, we have to train medical professionals, implement standardized protocols, and really get the patient narrative. We have to center the patient experiences to really meet them where they are. So I look to all of our budding future doctors to kind of take us forward with that. And what are patients doing? Patients are really taking matters into their own hands. And we've seen a significant and tremendous rise in the patient advocacy groups. And I don't think that advocacy groups are adversaries. I think they're groups that we really need to work with because they're basically bridging the medical office with the patient experience. They're oftentimes translating what has occurred in the office, and they're really advocating for the patients. So it really is our duty as healthcare providers and systems to really work with our community groups, especially the ones that are vetted, to get the information in the hands that it truly does need to. to get the goal of an empowered patient. An empowered patient is someone who understands what's happening with them and finds and seeks resources and can also seek a second opinion and get access. So the goals are the same, and it's not an adversarial thing. It should be something that we're doing together. We should never forget our teens. Again, they're my heart. And a lot of these programs are actually understanding that since this issue arises during adolescence, we really do need to target them as well. Our friend social media. There is a lot more data on social media than there is on disparities. If anybody wants to do a project on endometriosis on social media, there's things there. What do we know? People are using it. People are using it a lot. They're going there because they feel they're not getting the information within the medical office and the visit. People are validating the systems, and they're actually using it really nicely to build referral pathways. So there's a lot of plus with social media. The problem is most of the issue in social media doesn't come from experts. Now, again, we can't say evidence-based because I've already shown you the evidence is tainted, but from experts. And who's really leading the narrative? The narrative is being led by people with endometriosis, which is great. But it's also being led by a lot of people who are life coaches or pelvic pain coaches, and they're really getting a lot of information that is incorrect. So doctors are there. We account for less than 6% of the people on social media that's driving the narrative. And when we do post, people doesn't like the post. So we have to really work within our younger, more engaging people, I shouldn't say younger, in order to get the information, right? So this is just to show that allied health professionals actually have the most accurate information, and allied health professionals like pelvic pain physical therapists and occupational therapy. While the doctors were doing pretty good, but some of our information is just more for supplements. So finally, in my last minute, actually, I think we had a really good talk about the use of AI earlier, and this feeds right into endometriosis. How can we put into an AI tool information about a disease that we have very little information for still, or our information is very homogeneous? So if we're putting the data into these tools, because as we know, you still need the experts, but the experts don't even agree, we can already see the issues. But how do we get improvement? So there's a lot of smartphone apps that are out there for menstrual pain. And this is a study that was done in the Netherlands that actually showed that they just validated a smartphone app for endometriosis. But we know the Netherlands, the population there cannot be extrapolated to the US, but we're equally doing a lot of engaging app technology here too. And the apps can work. You can put your information in, you can bring this to the doctor's office and say, it thinks I have endometriosis, and it can tell you why. The problem is we have to train the tool, and we have to make sure that the tool has information that's going to pick out the different symptoms as well. So we do need to incorporate the doctors. After diagnosis, there's a lot of opportunities for treatment options from exercise and eating. So this is a great tool for the future, and the future shows that this is where a lot of the healthcare research is going. So again, another bit, endometriosis, budding OBGYN, this is a nice field to go into. Our chat bots, everyone uses ChatGPT. My patients come in all the time telling me chat says I have this, chat says I have that. So we do have to be prepared for it. And I encourage it, and we kind of go through the data. Looking at the chat bots, they're good for symptoms, but they're not good for treatment. So you could even use that in the office and say, okay, it's good for identifying, but I wouldn't use them to tell me what to do with it. Because we know that that's where they veer off. But some of the chatbots can be pretty accurate, and I think it behooves us to be on top of what's happening there. And finally, AI is really emerging as a leading tool for endometriosis research. There's lots of research going on for biomarkers. How do we diagnose without surgery? How do we use imaging? How do we diagnose with blood work? How do we get the patient experience? The issue is that there's a lot of issues with non-representative samples. Where is this information coming from? Where is the data coming from? And what is the quality of the data? And if we're putting poor data in, we're not going to be able to use it really valuable. So the question, if you look at any AI tool, if you look at anything you're going to use, is, are these tools inclusive of the diversity of patients that we aim to serve? So something as you will go through in your career, that's something we should always think about. Where is this information coming from, and does it reflect the group of patients or people that I am serving? So in summary, I've made it through. Endometriosis is quite common. It's not just in the pelvis. There's a lot of disparities. It's not driven by biology, it's driven by systems. We do need to make sure that when we're thinking about AI and anything that represents accelerated care, that it has the information is coming from a diverse subset, and we do have to be intentional with working within our patient advocacy groups. So thank you, and I'll take any questions if you all remember what I said, because I was on turbo boost, sorry.
Excellent, excellent talk, and we're impressed with your ability to go into 2 times speed and still get your point across. Very impressive. I think that's common now. And I know the med students listen to lectures at 1.5 or 2 times speed.
1.5. Well, they heard me.
You were very clear. Thanks for that great talk. We do have time for some questions. Do we have any questions from the audience here? While you walk there, I'll read one from the Zoom group. Thank you. This is from Dr. Velazquez. Thank you, Dr. Trotman, for a great presentation, and welcome to our medical and academic community. You highlighted a compelling call to action with several ways to address this issue. Beyond a single lecture or implicit bias training, which are important, which element should be prioritized in medical education if the goal is to change how clinicians respond to pain in Black individuals with a uterus?
Thank you for that. You have all the best questions. So we have to meet patients where they are. We have to center the patient experience. I don't think having a checklist of what a patient says is going to be there. So we basically have to get our trainees out of the exam room and into the communities, into the people that they serve. So there's a lot of cultural differences in how people present, how people report pain and things like that. So you may actually miss if you're just going off of a cure defined. So my answer for that is we really do need to have more patient-centered, which only comes from going into the communities that we serve in order to understand how do we best collaborate with them.
Is it on? Okay. As we start to investigate the role of GLP-1s in possibly endometriosis treatment, how do you think we can approach making sure that there's equity in the research related to that, or like diversity?
Okay, so how do we make sure there's equity with the GLP-1s and endometriosis? So thank you for that. So, it's difficult because, again, so few women are diagnosed with endometriosis, and how it's going to take a Herculean, if that's a word, effort to get. But what I think it's going to come from these endometriosis centers. So if you're going to where the highest risk patients are, and you're getting them there, and usually within the centers, you're having similar socioeconomic status, then you can start really bridging away and taking away some of the confounders and looking pound for pound with the patients. It's truly going to be very difficult if you're looking at it at a population level, because I don't think we're ever going to see the same access to the GLP-1s, particularly with the funding, that in order to get clear, unbiased samples. We also have different reasons in different communities for using GLP-1s. Are you talking about patients with diabetes and obesity, or people who are just using it for weight loss, or people who are using it for cosmetic? So but that would be a great NIH funded study, yes.
All right, thank you. Next.
I'm actually here with my 5 high school students that presented earlier today. So I have a 2-part question. One is, I know there was recent research, it's preliminary, saying that they're finding biomarkers to be able to better identify endometriosis without being invasive.
Yeah.
Do you think that that's going to help with the disparity in access to care, or is it just going to perpetuate it?
So yes and no. So the biomarker data that's coming out, I think it's fair, but it's a very homogenous group of people. And a lot of the work is actually coming from Connecticut, so not our neighbors next door. So I think time will tell as to whether this tool is going to be able to be used in a wide variety of populations. And one of the first images I showed you of this blast of enzymes, there's not one reason, and endometriosis doesn't have one phenotype. So I do think it is going to level the playing field a little bit more. I question how broadly it's going to be able to be used, but it is a step in a very positive direction.
And just really quickly, thinking about equity and my young scientists back there, what's one thing that you'd want them to think about as they're moving forward?
I'm sorry, I didn't hear the end of the question.
One thing that you'd maybe want to share with them to think about equity in science differently as they.
Okay, so equity is not a buzzword. And I think I've sat in many boardrooms where people says, oh, it's the thing of the minute. Equity has to be part of how you think about everything you do. So if you put it in as one of the core factors, almost not take it out, but it's almost a requirement. As much as if you're seeing a patient, you're like, what's your age, what's your date? You have to think about that person as themselves. Equity also doesn't mean giving people more. It just means helping them get to the space where they can then expand. So I think taking it out as an extra and making it a part of the core in every work you do, regardless if you're a researcher or a clinician, would be the answer.
Yeah, and I'll just comment, if you remember from Dr. Milligan's talk, when she put that Jenga puzzle,
yes, the E.
The E is equity. And as she walked away from the stage, I said, if you pull that E out, that Jenga piece falls apart. And people don't really realize how important that is to have that embedded in anything that you're doing. Thank you.
Hi, my name is Jiho. I'm actually with the New Visions program, but I actually remember hearing about endometriosis through social media, as you mentioned, this past year. And I wanted to ask you more about your opinion on why women are hearing about what seems like crucial facts in our reproductive health on social media rather than in our doctor's appointments.
Yeah, that's a great question. I was just on social media before we came, and I got onto this thing, and there's a GI thing. This patient has pain and bloating. Should they say GYN or should they see the GI first? And I looked at the comments, and the comments exploded with, I have endometriosis, and they missed it, and the doctors never told me. I do think the ship has sailed in traditional medicine. Now, is this being recorded? I know. But a doctor has 15 minutes to do your annual exam, your vaccine, and also deal with your issue. The person may or may not be able to come back for a problem visit. I think there's so many different factors with traditional medicine that you're getting patients that actually feel differently when they're able to get more direct patient care. So you're actually seeing some doctors leaving traditional health systems and doing the bad word of concierge medicine, but like they're kind of their clients and they are able to get more time with the patients. So I think the lack of time with patients is a big one. I do think physician education is a big one. I think that there's also it also is a disorder that's hard to describe and diagnose for many people. And there are times even in my practice where there has been a big conversation and the patient just didn't really understand the concept. But I do think we're losing it in the ability to spend time with our patients and engage with them on the level that they need, whatever that may be.
And just as a follow-up, going back to the AI portion, do you think, or can you see AI helping that an increase of time allotted with patients?
Oh, absolutely. And I think I feel like we should be using AI the minute the patient hits the door, so, with even education, if someone's coming in for pelvic pain, they can trigger that. I'm coming in for pelvic pain. You can actually go over their symptoms. So when they get to the office, you can actually now really focus that. And maybe endometriosis goes from being something you didn't think about to being something higher. So I actually do think AI can be really, really useful in getting us there. So I do think those symptom trackers, I do think those scripts that people get from social media and from AI, tell your doctor this, is going to be helpful. But we just can't use it for everything. We still have to put our minds in, right?
Thank you.
Yeah. Thank you.
Thank you. Excellent.
Thank you. Thank you, everyone.
So I'm going to be introducing our next speaker, Dr. Owen Garrick. Dr. Garrick was Dean of Clinical Trials at Mayo Clinic. Dr. Garrick led the transformation of Mayo Clinic's clinical trials and an ambitious strategy to bring the promise of clinical trials to more patients. Dr. Garrick earned his MD from Yale School of Medicine, which is actually when our paths crossed. So despite his extremely busy schedule, which I didn't understand what a medical student's schedule was like, he did take time to kind of provide mentorship and support to some of us undergrads coming through the pipeline. He also got his MBA from Wharton School of Business. He holds an AB in psychology from Princeton University. Dr. Garrick.
Thank you. Well, much appreciated. I assume everyone can hear me okay. I want to thank, I always call Mill because we are actually fraternity brothers. And it is an absolute pleasure to be here and to watch his ascendancy in the academy and to hear him acknowledge that I was at least very, very small part of that is quite refreshing. So thank you, sir, for inviting me. He's actually asked me to come a couple times, and schedules didn't exactly work out. So really do appreciate the fact that I can be here now. And in the event there is a evaluation at the end of this, please at least give me 1 or 2 5s. So maybe he'll invite me back next year. Give you a sense of my background. I am from the Bronx originally. Any Bronx natives here? Perfect, perfect. I grew up not too far from Yankee Stadium in the South Bronx off the Grand Concourse. Always wanted to be a doctor since I was a kid. Did not really think I would be a researcher per se, but I fancy myself now as more of an applied clinical researcher. And I'll give you a sense of some of the work that the lab I help lead now focuses on, really looking at and solving intractable healthcare problems. So in particular, and we look to use large data sets. So Dr. Milligan earlier mentioned the electronic medical record. We have a good 20-year-ish history experience with that now. So what my lab does is to use what we call multimodal data. So it might be EMR, lab data, imaging data, et cetera, have that longitudinal, i.e. 20, 30 years, and have a lot of it. So many millions of individuals across the US and across the globe. And so one of the ideas we have is solving and ending maternal mortality. So if we can look at the last 20 years in the history of the US and identify all the individuals that died from giving birth, and then retroactively or retrospectively see if there are any signals that we can identify that should have given us a pre-warning that they may have been higher risk, then identify some interventions to lead to, in essence, pre-cure this issue of maternal mortality. So that's sort of me in a nutshell. And during the Q&A, I'm happy to answer any questions about being pre-med, med, academia, and research. All right, I have a few themes today, and I'm gonna, for those of you, I'll give you a punchline because there are those of you that need to get back to your text messages or your social media posts. You can quickly do that. I would do it myself, but I think it's a little off-putting where if a speaker is actually texting while he or she is trying to provide some knowledge. But punchline is this: sometimes in life it's tough, and we're going to talk about at least in part the current administration's research priorities. And there are times in life you got to man and woman up, and life can be a bit challenging. And I'll say this: any administration has the right and the authority to decide what it wants to focus on in terms of research, funding opportunities, wars, education. Right? Those are choices that administrations make. But talk about a few themes here. One is taking the long view. I know in this world we try to react to things immediately and fast. The second, probably the crux of this, is really continuing to focus on your mission and values, especially during turbulent times. And one of the things many folks that I admire in healthcare and in higher education, they really articulate very clearly: excellence will always be rewarded. So really continue to focus on your core values. I'll give a few examples of sort of individuals that are bucking the system currently and how they fared. And then finally, to really, for all of us to be cognizant, we talk a lot, right? And I think folks learn our true values when they look at our actions, especially when there's pressure. All right. Make sense? Everyone good with that? All right. All right. So first question: how long is long? We often want to be the first or second to respond to a post, so we're talking seconds sometimes, right? Photo here. Anyone have an idea what this is? Give you a hint. It's from a small school in central New Jersey. This is actually Nassau Hall at Princeton University. As Mill mentioned, I went there undergrad. And I was on campus last fall for a conference, and that conference was in essence celebrating the 125th anniversary of the graduate school at Princeton, and they invited alums back. And as part of that conference, they offered a tour, and the tour was walking around and seeing some of the highlights of the Battle of Princeton, which occurred during the Revolutionary War. And Nassau Hall was the first building on campus, and the British actually commandeered it and used it as a fort against the American Continental Army. And during the tour, the individual who was given the tour mentioned, and it struck me, that Nassau Hall is older than the country, right? And that put this issue of time in perspective, right? So and my understanding is New York Medical College was formed in 1860, so still a very long time. So if you look at Princeton, Princeton has dealt with every single thing that the country has dealt with. A civil war, slavery, women's suffrage, pandemics, depressions, and it is maintained and it's been true to its original mission, which is why after 250 plus years, it's still around and thriving. And I think similarly with New York Medical College. So this notion of we need to overreact to this current administration, I think we should pause a bit and think about that. And if we can certainly make adjustments and tweaks to tactics, but continuing to be true to what your original mission is that built and sustained you, both institutionally and personally, I think is really, really and truly the point here. All right, let's get into some times when you can actually challenge authority and what happens. Anyone? I'm sure no one knows who this guy is. His name is Gregory Washington. He is a mechanical engineer by training. His research is really in the area of smart materials. And he's currently the president of George Mason University, which is in Northern Virginia. He was born in New York City, and he was the first in his family to obtain a college degree. University president, Harlem-born, first kid in his family to obtain a college degree. This is a picture from a New York Times article a few months ago, and he was featured in that article because President Trump actually demanded a personal apology from him for Dr. Washington's support of diversity at George Mason University. So you've heard about the attacks on different universities and academic environments, but this is also, one might describe, a personal attack, wanted a personal apology from him. Dr. Washington said no. He's a New Yorker, I'm sure in private he said, get the F out of here or something to that effect. But he pushed back when virtually no one at the time, talking a few months ago, pushed back against the president. And this is, he's not in New York, not in Connecticut, not up in Boston, in Virginia, right? Which is, Virginia, sometimes in national elections swings Democrat, swings Republican, but they have very conservative individuals on his board, some liberal, some moderate individuals. He came on to the university in 2020 in the middle of COVID, right? So really, really has been sort of in the mix and decided that academic integrity and independence was critical. And if no one was going to stand up to the president, he was going to be the first one. Since then, the faculty senate at George Mason has come on board. He's clearly convinced his board. He hasn't resigned, right? So taking and having some amount of courage in times, because I think when we see our true and we show people our true values and character during inconvenient times. When life is easy and it's good, it's very easy to be focused on diversity and your values, but you start at somewhere during COVID, not really deep South, but the South, and then when other institutions, I'll be frank, have folded and caved in to the current administration. This band refuses to, and now he's garnered the support of the rest of George Mason, and also others across the country are saying, all right, he might have been the first, the early adopter, if we want to use a technology perspective, but there is sort of hope here. The next point, or the next slide, is really talking about ebbs and flows. Life really is not linear. So it's not, I don't like living on a roller coaster, but life hasn't always been great, but it's been pretty good, but not always great. So I want to talk about this next point here is you get wins only if you're in the game. This is from a few weeks ago, right? So there are individuals that pushed back against the Trump administration, took them to court, won, and the Trump administration decided not to even follow up with an appeal, right? And there was a reference to, I think Dr. Block talked about the Super Bowl earlier, and you often hear defense wins championships, and I think that's true. But sometimes you got to be proactive and go out there and offense because somebody has to score a few points, right? And so there are these individuals that were proactive against the government. Got I think, a very, very good win. That photo is of Secretary McMahon, who is the education secretary. So a lot of losses for a good amount of time if you are focused on and you believe in diversity and equity in research and in education and in educational independence. And this group of individuals put a very, very strong legal case together and got won in court and then got the administration to back down. So final points I want to talk about is how we define teaching. And as I mentioned before, I think people see our values in our actions, in addition to the things we say. And I have a couple quotes here. But the punchline again here is that we are really all in this together. The second quote is, I was actually in church on Sunday. I don't know if folks still go to church nowadays, but I was in church on Sunday, not for any particular reason. I just love church. And the pastor there said something very interesting. He said, and this gets to this, we're in this together perspective, right? He said, it takes people that are not overwhelmed to free those who are overwhelmed. He had a few references to Jesus and all that other stuff, but that point I thought really, really hit me. And then the second is a good friend of mine who's a communications professional. And she talked about the reality. This is a post she had on LinkedIn a few weeks back, talked about the reality of the current environment, right? And I'll just read it to you. And she says, and to be fair, I understand why some are quiet. Having a voice right now can feel risky, exposing, exhausting. Not everyone has the margin to speak loudly in moments like this. So there is some risk you take, right, when you're in these tough environments and you step up and stand out. But that's the risk as scientists we always take, because in science, at least in clinical research in my field, you lose most of the time, right? So it takes, if you look at drug development, for every 10,000 compounds that are evaluated, one actually becomes something that is clinically impactful. Like that is, you got to get comfortable with getting some L's, right? And so this ability to accept risk, to accept the pressure, especially when you're focused on, and we're all here focused on patients, impacting lives, improving health outcomes, I think is really, really worth it. So that is the end of my prepared remarks. Again, I just want to thank you for your time. Again, a couple 5s, a couple 4s, spread it out would be fantastic. So Mill and the team here is kind enough to invite me back. Thank you.
Thank you very much for that great talk, especially with the historical lessons. I think always good to look at history because we know, you've heard the cliche that things will repeat itself if you don't study the history. So thank you for sharing a lot of those points, and especially that story about the university and the importance of standing up.
And it is my pleasure to introduce our last presenter, Dr. Trenard. Joined Metropolitan Hospital in 2019 and currently serves as the Chief of Pulmonary and Critical Care Medicine. Her research interests include health equity in pulmonary medicine, specifically improving lung cancer screening utilization and smoking cessation rates in vulnerable populations. Let me welcome and looking forward to your talk.
Hi, everyone. Thank you for that introduction. My name is Nicholls-Biondi Trenard. I'm a pulmonary critical care doc at East Harlem at Metropolitan Hospital. So I've worked with a couple of you guys already and rounded with a couple of you guys in the ICU. So what I'm going to talk about today is going to focus on lung cancer screening, but I think conceptually will embody a lot of what you heard today. So let's get started. I'm going to take you back just a couple years to COVID. And the reason for that is because I want to share with you some patients that I met during that time and share the impact that they left and patterns that I observed. So the first couple of patients I had during the pandemic in 2020 all sort of presented the same way. So I'll read one or two. So these are actual patients that never left me. First patient was a 50-year-old Hispanic female, 3 kids. She lived in a shelter. She presented with shortness of breath. She had low oxygen levels, mild symptoms. And I remember we referred to her amongst my ICU colleagues as the happy hypoxemic. Her symptoms progressed. She was intubated after 1 week. It was a 65-year-old Black male, history of diabetes, hypertension, hyperlipidemia, CAD stents, again, presented with fever, cough, shortness of breath, initially had minimal oxygen requirement, quickly progressed, got intubated, was in the ICU, and that was sort of the pattern we were seeing. And so these patients sort of represent that same pattern. And so initially, a little bit after the pandemic, I was asked to do talks about what were our patients dying from in the ICU in East Harlem. So initially, my talks focused a lot on acute hypoxemic respiratory failure, right? So acute respiratory distress syndromes. I was showing x-rays, normal, abnormal ones. I was talking about the pathophysiology. What had escaped me was the other pattern that we were observing. When we started to look more at the information we had, we saw that outside of ARDS, what else was killing our patients, right? So my patient population was actually more likely to get COVID. They were more likely to get severe COVID, meaning they were more likely to get intubated. And there was no genetic predisposition, we found. Their alveoli looked all the same. What was more likely and prevalent was that they were more likely to be living in crowded conditions. They were from congregate settings. There was a heavy reliance on public transportation. They didn't have the luxury of sheltering in place. So what I started to see was that I was only seeing, as a clinician, half of the pattern, right? The pattern that focused on the pathophysiology and what only partially impacted outcomes. Now, looking back, there were other patterns, right? First patient was a Hispanic female, 3 kids, undomiciled. Next patient was a Black male, multiple comorbidities, which increased his risk of severe COVID. So a lot of patients followed that same exact pattern. So I realized I wasn't comprehensively understanding my patient population, so I couldn't teach it in that manner. So I re-asked myself what actually was killing my patients during COVID. And so you must be asking, I thought you were going to talk about lung cancer screening, but I'm going to tie it in for you. As I started, so a couple years after, we developed an EBUS program at Metropolitan Hospital. And EBUS is basically the standard of care for diagnosing and staging lung cancer. And so now I was looking for patterns. So this was our first patient actually that we did an EBUS on. She was a 67-year-old Black female, active smoker, 30-pack-year smoking history. She was admitted to inpatient psych for auditory hallucinations. She complained of productive cough, weight loss. The psych resident ordered an x-ray. She had a big left hilar mass. They called us. We did an EBUS. We diagnosed her and staged her. So she had advanced stage 4 squamous cell carcinoma. For us, we thought we were successful, right? We got a diagnosis and we got her staged. Second EBUS patient was sort of the same thing. Again, another pattern. She presented, it was an incidental finding. They called pulmonary, we did an EBUS, we staged her, again, advanced lung cancer. So now I was asking myself a little bit more promptly, what's the pattern I see? So as a pulmonologist, it felt like a win. But what I realized is that both patients should have been screened a long time ago. And had they been screened 10 years prior, when they still qualified for screening, their prognosis would have been a lot different. So I'm going to talk now a little bit about lung cancer screening and sort of identify the problem that we're having with it. So lung cancer, as many of you know, is the leading cause of cancer-related deaths. It's strongly linked to tobacco smoke. About 80% of deaths are related to smoking, and 20% of deaths are never smokers. And there's other risk factors that could that contribute to that. And we know that staging impacts prognosis. But what we need to do is prevention and early detection. So we know those two things save lives. So this is just a little bit of data to kind of drive that point home, and so you can sort of like understand where our patients actually fit in. So the 5-year survival rate of cancer is about 28%, right? And the main reason for that is that most patients are actually identified when there's distant metastasis, when the prognosis is very poor, right? So you can see here, I'm trying to show, essentially depict that most patients are diagnosed when lung cancer is advanced, and that directly impacts prognosis. So most patients are being diagnosed when their prognosis is pretty poor. But if it's localized prognosis, it's actually potentially curative. Now, if we look a little bit deeper into that, we also know that lung cancer doesn't impact everyone equally. So amongst Black males, they have the highest incidence of lung cancer, the highest mortality, and highest smoking prevalence. But there's actually something we can do about it. So this is a landmark trial, which I won't go too into, but I will just sort of cover some history about how we practice pretty much. So in 2011, the New England Journal published the results from the NLST, so the National Lung Screening Trial. And it was a huge randomized controlled trial that looked at over 50,000 patients, and they basically identified that screening with a low-dose CAT scan would reduce the mortality by 20%. So lung cancer specific mortality would be reduced by 20%, and all-cause mortality was reduced by 6.7%. And the inclusion criteria they used was as stated here: age 55 to 74, 30-pack year smoking history, and if former smoker, they had to quit within 15 years. So as mentioned, there was increase in detection of lung cancer, and then also decreased mortality. The other thing to note is that the number needed to screen to prevent one death with lung cancer screening is 320. To put that into context, the number needed to screen to prevent one death in breast cancer is 1,904, and colon cancer, 1,250. So a lot less people need to be screened to prevent one death. So based on this, the USPSTF made recommendations, right? And so they recommended that patients within age range of 55 to 80, 30-pack year, and current or former smoker who quit within 15 years should be getting an annual low-dose CT because we know it saves lives, right? So it's great news. And then this data started getting analyzed. So they started looking at racial differences in outcomes within the National Lung Screening Trial. And so what they found was that among all racial groups, current smokers had worse lung cancer specific mortality. However, the risk was twofold higher in Black current smokers than in white individuals. And all-cause mortality was 1.35 times higher in Black individuals than white individuals, right? And so these they looked at the patients who were screened with low-dose CT, and you can see here that it benefits all races, but it actually benefits Blacks a lot more than other races. So you see here in figure A, screening for lung cancer with low-dose CT is beneficial in also all racial groups, but it resulted in a highest reduction amongst Black individuals. And in all-cause mortality, Black individuals screened with low-dose CT had a significant reduction in all-cause mortality, which is this Kaplan-Meier curve here. So if we look even a little bit closer, though, this huge trial, which was a success, right? If you look at their patient population of their study, you'll see that almost 90% of the patients here were white and 4% were Black, right? and they noticed there were demographic differences between the two groups. Amongst Blacks, patients were younger. There were fewer had formal education. They were less likely to be married and had more comorbidities and were more likely to be current smokers, although their overall cigarette consumption was less. So now, if we think about this, and we see that basically guidelines were developed based on this information here, you can understand why there would be implications in terms of screening guidelines that are supposed to be applied to the general population. So as expected, there were disparities based on these guidelines. So despite the higher risk of lung cancer, Black people were actually less likely to be eligible for lung cancer screening than whites under the 2013 recommendations. So we recognize this, and there were revisions. There were revisions in 2021, which reduced the number of pack years. So you were able to smoke less and qualify for lung cancer screening, and you could be younger. And this reduced, but did not eliminate the Black and white racial disparity in lung cancer screening. And now there are studies that are looking on how to simplify the pack year even more. So there are proposals now to eliminate the pack year, where there's actually a calculation, and just make it a lot simpler, and you ask the patient, how long have you been smoking? So if they smoke about 20 years, which is a 20-year criteria versus 20 pack year, more patients would actually qualify for lung cancer screening. And it is said in the studies that they reported that this would eliminate essentially the disparity. So this is great news, but there's still a huge problem. There's underutilization of an evidence-based intervention that we know saves lives. And in general, lung cancer screening is underutilized, about 5 to 20%, depending on the state. But amongst Black males, where we have the highest mortality, the utilization rate is 1.7%. So the other problem also is that this trial, the participants were adherent about 95%. So it wasn't that they caught cancer on the first scan they did. They caught cancer on serial CAT scans. So you needed to be adherent to actually realize that reduction in mortality. Adherence is a problem amongst Black males. So realizing that mortality, patients have to keep showing up. And what we know is that certain cohort studies show that there's a median adherence rate of 53% in real life compared to clinical trials, and then even lower amongst Black males. So in no way am I suggesting what I'm going to talk about in my next slides is going to be the problem, the solution to the problem with lung cancer screening and health inequities in lung cancer screening. But I've talked to you a little bit about eligibility, the disparities in eligibility, early diagnosis, but there's also disparities in treatment and smoke and quit rates. We're going to focus a little bit today on early diagnosis. In 2020, the American Cancer Society sort of identified what are these barriers that we're facing that is promoting this underutilization in lung cancer, right? So what they identified, just very briefly, was that there's a lack of awareness. There's people who smoke are less likely to be educated, less likely to have a PCP, and this reduces access to lung cancer screening. And there's an inverse relationship between patients who are actually at highest risk and who have access to lung cancer screening. And as we mentioned, the existing guidelines overlook ethnic and socioeconomic risk factors. So the dilemma, we currently have a referral-based system that's heavily reliant on having a primary care doctor, meaning you only get lung cancer screening if you're referred by your primary care physician. We identified that a lot of these high-risk groups don't have access to care. So how will they get lung cancer screening? So screening remains inaccessible to the most vulnerable with our current model, right? So there is a study. This came out of Boston Medical Center, and I just wanted to highlight it because it looked at their utilization rates, people who had received care in Boston Medical Center. So just very briefly, they identified current or former smokers, about 8,000, looked at about 3,000 charts, and then decided whether they were eligible or not based on the information. And what they found was out of 615 patients that were eligible, 516 patients were not screened. So I also want to highlight that despite having access to care, there was still a huge percentage of patients that were eligible that remained unscreened. Who were those patients? They were older, they were African American, lower annual household income. So we still have the dilemma, right? The lack of access wasn't the only problem here, right? Patients who do have PCPs or some access still are not getting screened reliably. So I want to go back to our patients that I introduced you to who got those first 2 EBISs at Metropolitan. They were both unscreened at time of diagnosis, but they were identified during a hospitalization. So my question became, can a hospitalization be the way we extend the reach of lung cancer screening in a safety net hospital for this high-risk demographic group? There's not much data to actually support that. There is one study, a very small study, also out of Boston, that looked at maybe initiating shared decision-making as an inpatient. And so it's a very, very tiny study. They had 2 pilot randomized controlled trials. And they basically looked at inpatient SDM, so shared decision-making, where they approached hospitalized patients about lung cancer screening, versus enhanced usual care, which was basically the nurse practitioner gave the patient a pamphlet and asked him to review on his own or her own, and then discuss with their PCP whether they wanted to pursue lung cancer screening. And then the other study is like they integrated a navigator into that design. So what they found, I'll sum it up for you guys, is pretty much that with the navigator, there was some promise that you could engage patients during a hospitalization for lung cancer screening. And qualitative interviews showed pretty much on the provider side and also on the patient side that there were favorable attitudes towards doing this, and they found that it was feasible and generally favorably viewed being screened during a hospitalization. So my question became, could we use this hospitalization? Could we use a patient's hospitalization as an opportunity for engagement and leverage basically existing infrastructure instead of trying to redefine how we do things completely, or redefine it, but with existing infrastructure? So I just wanted to talk about Metropolitan Hospital. It's a small community hospital in East Harlem, serves mostly the demographic I just described to you, right? So lower socioeconomic income, mostly Latinx community, Black community. And so would it make sense to be screening these patients? So we got a small grant to do this work. The title of the study is called Inpatient Capture. It's a mixed method study evaluating an inpatient lung cancer screening program in a safety net hospital. One of the things I wanted to mention is we got the grant, began the work, and it was defunded for a lot of reasons that were mentioned today. Luckily, we were actually given back that funding, but it did slow things down, but we are now progressing. We were able to complete AIM-1, which was basically a qualitative piece of our work. We conducted a formative analysis through focus groups with stakeholders across the medical center to assess feasibility and attitudes towards an inpatient lung cancer screening program. And our second part is actually the single-arm pilot trial where we will be doing inpatient lung cancer screening. So we've begun enrolling March 2025. To compare to the previous study that I just mentioned, our patient population looks a little bit different. So some of the things they did there is they incorporated this screening through their tobacco inpatient visits. So all of their patients had to be smokers for them to get screened. Our patients will be all comers, so former smoker or current smokers. They excluded patients who didn't speak English. Our study will include both Spanish speakers and any other languages that we have translations for. Another key difference is that they excluded patients who did not have a PCP. Again, our patients that we're going to be looking at will be all comers. So anybody who's hospitalized will be screened for lung cancer screening, and eligibility will be confirmed. So just very briefly, this is sort of what our design looks like. We're going to pre-screen every medicine admission. So just based on the chart, we're going to decide whether patients could potentially be eligible. And then eligibility will be confirmed by our nurse practitioner. Once their eligibility is confirmed, they'll be consented if they decide to enroll, and we'll decide either if they meet lung cancer criteria and they're a former smoker, so they'll receive inpatient shared decision-making and at the very least get a referral to our lung cancer screening. But our hopes will be to give these patients an appointment for the low-dose CT, so we can give them something tangible for them to follow up on before they leave the hospital. If they meet lung cancer screening criteria and they're an active smoker, they'll get everything they need for lung cancer screening, either a referral and also an appointment for their low-dose CT, but they'll also get smoking cessation counseling, handouts, and a referral to our smoking cessation clinic. And if they're not enrolled, they just declined, we're going to try to obtain reasoning for them declining services. Our primary effectiveness outcome will be up-to-date status on lung cancer screening at 3 months of discharge, and then be comparing that to the pre-intervention period. So we'll be looking at pre-intervention and post-intervention periods and comparing our status of lung cancer screening completion. Our secondary outcome will look at smoking cessation rates, referral rates to our smoking cessation clinic. So I just have some preliminary findings for you with our AIM-1. We were able to recruit through community-based organizations in East Harlem participants for our focus groups and our interviews. We conducted these interviews and focus groups through August 2023 to January 2024. And this is what our patient population generally looked like. And I only share this with you just to highlight that it's the demographic we were looking for. It's the demographic we were expecting, and also the demographic that we know is at high risk for being missed. And what we found was that 77% of patients agreed to be screened during a hospitalization, and 73% would want their low-dose CT before leaving the hospital, despite half of them acknowledging that they would be overwhelmed if approached. 55% of patients said that they would want inpatient smoking cessation services. And regarding barriers to inpatient tobacco screening, about 63% disagreed it would be overwhelming to them. Some of the participants quote, they said, yes, since you're already in the hospital, you should take advantage of the opportunity to have the test. Some of our providers, we interviewed them as well, and they found basically this could be a way to offload primary care physicians. They thought that this would also be an efficient way of screening and maybe an additive strategy to improve utilization. Some of the providers said, and for those who don't typically come, this hospitalization is our chance. Yes, it's a very big opportunity because every encounter for a patient with a healthcare provider is a chance to stop smoking. I won't read you the rest of the quotes, but they were all favorable. And I want to highlight here that an inpatient strategy here might circumvent some of the outpatient barriers that were identified. So time constraints were a huge thing that people said could be limiting utilization for lung cancer screening. There's a lack of community outreach, so maybe this type of program would increase visibility for lung cancer screening. There was a lack of education among patients. Again, maybe this could serve as the first time they're exposed to this topic. And then there was a report of inconsistency in being offered screening. So patients felt that they were not being screened consistently in the outpatient. I'll include this really quick because it did change the way I do things. One of the things that came up during the focus groups were that a patient said that essentially they would be worried about cost and they would be embarrassed to bring that up during a shared decision making, so they would decline it without actually asking further about it. So now I've incorporated costs to the patient in my shared decision making, which was not something that we routinely did before. So just to give you an update, AIM-2, we have about 134 people consented and enrolled. We started March 10th in 2025. I'm hoping at the next conference, I'll be able to present those results. My take-home points today are that lung cancer screening saves lives, and we have an evidence-based intervention that's not getting to our vulnerable populations. So this idea of health equity is not something controversial, or it shouldn't be. It really is about science and delivering effective care. So to me, this is just about medicine. Thank you.
Excellent, excellent. Thank you so much. Yeah, a lot of times, people think it's what do you call it? Going to the moon, just to it's complex to try to give people good medical care. We know how to do it. We just need the right tools, the support to reach out to those masses, and we can improve the care of our nation, really. And we saw those numbers earlier from Dr. Block, Dr. Budhu, about how we're spending a lot of money, but not getting the full benefit of what we're expending in our healthcare. Do we have any questions?
I had like two questions. First, when a patient is hospitalized and they consent to be a part of your study, do you guys schedule for them to come back and do another screening when the time comes, or?
So the screening is actually just the identification that they're eligible. But actually, you can't do the low-dose CT during that inpatient hospitalization. That was a problem the administration sort of put forth, because we won't get reimbursed because it's no longer, it's supposed to be an outpatient study. So the patient actually has to be discharged. What we try to do is, because insurance has to cover it, And so we need time for that. We try to get them an appointment before they leave. So they definitely have to come back, but we would like to give them as much information as possible to influence them coming back.
Thank you. And then I had another question that's just because like I know I've seen like sitting on the subway things like ads for like colon cancer screening or things like that. Do you think because a lot of the issue is like whether patients are going for screenings or whether their PCP is recommending it, do you think that like lung cancer screenings would benefit from ads like that?
100%. I mean, that's what we're trying to get to. I mean, but the breast cancer campaigning, I remember a patient during one of the focus groups said, I see a pink bus every other block. Like, why I've never heard of lung cancer screening before. So the idea is to improve outreach, improve campaigning. I think a lot of it has to do with awareness. So education is major, but I think community outreach with hospitals that work in safety, like hospitals that work in these or hospitals that serve this population, a lot of the onus is on us to provide that. So 100%, I think we would benefit a lot from it. A lot of the patients had never heard of lung cancer screening before we actually conducted these focus groups.
Thank you.
Thank you for your presentation. I was wondering if you had any tips or any takeaways from things that proved to be more effective. You mentioned talking about cost. Was there anything else that kind of really swayed those interactions, whether it be ethnic or identity concordance between the physician and the patient, or if it was just skill of the interviewer? There's something that kind of stuck out to you that like came up as a theme.
Yeah, it's a good question. I think there was a lot of investment in like the communication part of this because it was a study, and I think patients didn't feel rushed. I think that had a lot to do with them feeling, that we were present and may have influenced like whether they decided to go forward with it. But I think we had time to explain things and carefully. We had time for questions. I think that had a lot to do with maybe influencing. In terms of your questions about patient-provider concordant, it actually came up. I'm not sure. I mean, I'm not, this came up before. I was the one going into the community and doing focus groups, and a lot of the patients participating in focus groups looked like me. Whether that helped and allowed people to be more open about their experiences, I would say probably, and there's data to support that that's the case. But should that limit, like I can't do it by myself. So, other people on our team are of different races, and I think have experienced success in recruiting patients. But it's a good question and one we think about. But.
Yeah, because some of what I was thinking of is even the med student experience. The medical student might ask something, and then the attending comes in and asks the exact same thing, and you're like, how did that response turn out so differently? So that's kind of that's why part of the idea of the question.
Yeah, I didn't experience that as much, but I do feel like since I was part of the team, it could have influenced. And then I also speak Spanish. I think that had a lot to do, even if the focus group was conducted in English, there were moments where we spoke Spanish. I think that may have provided some comfort and just automatic trust that I think sometimes is needed to, get people to listen. So I think it helped for sure.
Thank you so much.
Yeah. Yeah, trust is so complicated. This morning, Dean Sozo, the head of our student financial services, he showed a slide and he showed the most trusted profession in America was, you guys remember what it was? Doctors. And it was like something like 86%. It was pretty high. Scientists was in the 70s. Politician, what was the lowest one? What was their number? Like 15% of Americans trust politicians. They vote for them, but that's the level of trust they have with them. But interestingly, one of the things I find interesting about trust is when AI came out, how many of you started using ChatGPT or some other AI platform? Nationally, people are just using it constantly. And what did ChatGPT do to gain your trust? And people just flock to it. And so something happened there. That trust is very tricky, and it's really nuanced. And how do you actually go about getting trust? And there are people who have a lot of expertise on it. Obviously, it's great that you were able to do that for these patients. Makes a huge difference. And that is a factor, I think, also in the patient exam rooms. If a patient trusts you, one of the things I go over is when a patient trusts, when a person, anybody trusts you, you share more. Who here has a bestie? Yep, you got would you tell me things that you tell your bestie? No, you wouldn't. You don't trust. I just met today. You're not going to tell me all that stuff. I haven't gained your trust yet. And I probably never will get to that level, right? So that's the thing, is that there are ways to do it. And it takes time, and you have to, it's hard to get it. You didn't just meet the person and become besties the same day. But it's also very easy to lose it, right? We all know that. So, but thank you very much, Dr. Trenard. Excellent talk with multiple levels covered in there. Yeah, so I got two of my wish lists crossed off. I've tried for years to get Dr. Trenard to come speak. She came this time, although it was my fault in prior years. And Dr. Garrick finally came out. So off my bucket list. So we're coming to the end of the conference, but before we actually close, we do want to just quickly just highlight a couple of things. Obviously, we learned a lot from the day. I don't know if you wanted to. Do you have a recap from the day you wanted to share, or no? No. Okay. Yeah. So we heard about different AI. I just touched on the trust piece, how important that is. I loved Dr. Milligan's Jenga of showing how to responsibly use and incorporate AI into your life. And as she walked off the stage, I said to her, if you pull that equity piece out, that Jenga thing falls apart. So you really need all those pieces in there to really move forward the way we're doing. But before we close the conference, as you all know, today, before the HeLa conference started, from 12 to 1, we had our students, some medical students, and then some high school students who were presenting posters and oral presentations. So we do want to briefly highlight, we're going to have Rahim come back up to just highlight some of those students, particularly the high school students who presented, and anybody who's not in medical school yet. That's it. Let's put it that way. I think we're going to highlight one medical student too. So Rahim is an M.D. Ph.D. student here at NYMC. He's actually wrapping up the PhD portion this spring, and will enter next month. And then he will be entering his clinical years. So long journey, almost there.
Yeah, he made me, sound really old, but apparently not really. Okay, no, I'm kidding. So as Dr. Etienne mentioned, we would like to, first commend everybody who presented here today. And thank you for listening to all the great talks and, abstracts and poster presentation and oral presentation. But we also specifically want to commend, some of the students who are in the pipeline, trying to apply to medical schools, and one mentor to, help them through that part. So first, we have a student, Maximilian Fanter. Come up, please. Yes. So Maximilian is a pre-med now in the pipeline to apply to medical school. So we wish you good luck and from the front. And congratulations on your presentation.
Max is a graduate of Stony Brook University and looking to apply to medical school. Thanks. Yes. We're going to go like this. We flank him.
Yep.
Yes, Chase.
And we have a student mentor, medical student mentor who is helping Maximilian here, Chase Goldberg.
Yeah, so we think it's very important. Chase is a M4 going into internal medicine. I think I know where he's going to match, but I'm not going to say it here. I'm very impressed with him. And he's been mentoring Max on his project, so we thought he should come up here and get a certificate with him. Thank you so much.
Thank you. Now we have a very special bunch of students. I don't know how they are doing it or what they are doing it or what they are eating, but I was not doing this when I was in high school. So we would like to commend our students who presented here today who are in high school. And we would like to congratulate them and we would like to give them their certificates, starting with Anya Korana. Secondly, Stella Mayers. Emily Wu. Jude Al-Mufti. And last but not the least, Livia Lowe.
Yeah, we strongly believe in, pipeline pathways. People say, oh, we don't have enough doctors here, not enough doctors there. I just say, you make your own. Go find them, go beat down those, elementary schools, find the high schools, find that talent, and you start really nourishing it, and you find these people who are going to be amazing doctors. And you know what they like to do? They like to come back to their community, and they like to come back and like to help and do those things, and then they end up mentoring the same folks coming up the pipeline. So less work for us. They're going to start doing it. They go out and they do it, and you've got a nice cycle of producing new future doctors, future researchers, and really just amazing. So we commend you all and the amazing leadership from your schools also just for coming out. So can't remember your first name. Priya. Yes, that's their faculty advisor. She came down with them. I think it's awesome to just really be motivating these students to do this amazing work. And if we were to tell you the titles of their research projects, it would just blow your mind. It's just, it's really amazing that they're able to do this high level of work at that stage. But that brings us to the end of our program. Once again, thanks to the Macaulay Honors College for coming out. You guys are awesome. You've been here since 9 o'clock this morning, 9 to 5, like a job, but you didn't get paid for the day. You got paid with knowledge, though. Lots of good knowledge you got for today. Thanks to the New Visions program, came from Rockland County. You guys are awesome. Came across the bridge. And of course, Horace Greeley High School for coming down. Thanks to all of our wonderful speakers. I think I learned a ton about many different fields that aren't my own field. And this is really how the idea exchange works. So that's all I have. That's it. Yeah. And yep. So that concludes our conference for this year. Be on the lookout for next year's announcement for HeLa conference. Thank you. Have a good night.